And now it's my pleasure to introduce Dr. Rashmi Srinath, who is Assistant Professor in the Division of Endocrinology, Diabetes, and Bone Disease, and Director of our Weight and Metabolism and Management Program. So, Associate Professor, also promoted. Okay, excellent. Congratulations. And I'll pass it on to you.
Great. Thank you, Mina. Well, welcome, everyone. Today, briefly in the 30 minutes I have, I'm going to talk about sort of the role of lifestyle, medical, and surgical approaches for management of obesity, as well as their role in managing MASH and MASLD. So in terms of disclosures, just to mention, I have some research support from Dexcom, looking at the use of Dexcom in obesity patients. In terms of objectives today, we're going to briefly overview epidemiology, pathophysiology of weight gain and obesity. And really the bulk of today's conversation will be about talking about the role of lifestyle modification, as well as pharmacotherapy and bariatric surgery, and how these can impact our patients. So many of you are familiar with these maps, but I present this because this was actually just released recently. This is showing data from 2022. So very concerning. Prevalence of obesity we know is on the rise, but now, as you can see, there are now 3 states highlighted in dark red, where the prevalence of obesity is more than 40 or 45%, which is very concerning. And obviously, these are states sort of more towards the south. As you can see, there are a few states still highlighted in yellow. And what they do point out is if you go look at these maps maybe 10 years back, there were no states highlighted in orange or red. So we know that this is, again, growing. There is growing concern. This is played out with COVID and all these other health, pandemics. So definitely something to keep in mind. What I also want to point out is that weight and obesity is multifactorial. It is not just our physiology. It is not just our genes. It is the environment we're in. It is hormonal. It is related to behaviors, eating behaviors. It is related to also cultural and social factors. So again, thinking about this sort of in a bigger perspective. We now are shifting in terms of how we approach this. And rather than thinking about weight in terms of a number and addressing patients based on what their weight is and where they should be, we're really trying to think of this more in terms of a bigger perspective and thinking that, okay, we really have to approach this in terms of thinking about their weight, but also thinking about what is the context and what is the degree of complications and how severe are these complications, because that's really how we're going to address and how we're going to manage patients who need us. And I bring this up because I'm actually on the committee where we're updating this obesity algorithm, but this is sort of a highlight of what's to come. So we are developing guidelines really to emphasize that, yes, we still start with addressing the patient, addressing their body mass index, and then we actually have to stage them. We have to assess how severe is this obesity? What are the complications associated with it? And for those patients, and as you can see, green is stage 1, there are no complications. As you go towards the right, patients with stage 2 have maybe 1 mild or moderate complication. Stage 3 obesity have more than 1 severe or multiple complications. And these are patients that you're going to manage much more aggressively, thinking in terms of how we approach their nutrition, their physical activity, their sleep hygiene, and counseling them around use of medications and surgery. So again, as patients develop more severity of complications, more aggressive interventions are needed, focusing on more behavioral, lifestyle, and medical and surgical approaches. And the question always is, what is our target? So we know that weight loss is a target and really a surrogate for improvement in other cardiometabolic risk factors. So ideally, we say 5% is sort of our initial threshold. We know that will help patients improve their health overall. Ideally, at least 10 to 50% is our goal. So if we can help patients lose at least 10 to 15% of their body weight, we can help them in terms of potentially treating their liver disease, treating or developing remission of their diabetes, as well as helping them from the perspective of heart disease. So again, thinking about targets and ideally at least 10 to 15% really is warranted to help patients in terms of remission and treating their comorbid conditions. So next, sort of jumping ahead to how we use lifestyle and sort of medical and surgical approaches. So many of you are familiar with the role of nutrition. So what I generally tell patients, just to start losing weight, we need at least some sort of caloric or deficit in energy expenditure. So on average, that means we have to cut out at least 500 calories a day just to start jump starting weight loss. For females, that means equivalent to 1,200 to 1,500 calories a day. For men, about 15 to 2,000, excuse me, 1,500 to 2,000 calories per day. There are numerous diets out there. We can characterize them as those that are under 1,000 calories as sort of very low calorie, and then those are generally between 1,000 and 1,500 calories. And so there is a broad umbrella here. You can include the low fat, the low carb, Mediterranean, intermittent fasting. They're all sort of in a similar range in terms of caloric intakes. And patients always ask me which is the best. So this is actually a recent meta-analysis looking at the risk of mortality cardiovascular events and comparing the most popular dietary interventions. So here you can see this was a systematic review with meta-analysis of 40 randomized controlled trials comparing Mediterranean, low fat, very low fat, modified fat, and low fat, low sodium, the Ornish and Pritkin diets. And what they found is that really Mediterranean low fat were the most effective. So Mediterranean helped in terms of reducing all-cause mortality, cardiovascular mortality, so highlighted at the bottom here in the green, as well as stroke, non-fatal MI. And the low-fat diet helped in terms of reducing all-cause mortality and potential non-fatal MI. So again, thinking about how these diets compare, and again, this is a meta-analysis, we have to take that with a grain of salt, but in terms of looking at sort of larger outcomes, we know that some of these diets are helpful. There's been a lot of interest more recently. Patients always ask me, what about intermittent fasting? So there was a big article in the New England Journal of Medicine last year with a population out of China where they compared intermittent fasting with caloric restriction. And they found there was no significant difference over a year in terms of weight loss outcomes or metabolic parameters. So this was a similar study, 88 subjects from China who were followed for approximately 12 months, average BMI 32. And they all had some sort of non-alcohol, I would say NASH or MASLD. Previously, this was developed earlier before the nomenclature change. But what's interesting is that they were randomized to time-restricted eating, finishing between 8 and 4 p.m., or direct caloric restriction. They were all taking in approximately similar calories. So this was controlled, 1,200 to 1,500 calories in women, 18 to 2,000 calories in men. And over 12 months, there was no significant change in terms of metabolic parameters, so weight, fat mass, lean body mass, as well as changes in liver. So they did look at liver stiffness, resolution of liver disease, as well as intrahepatic triglyceride content, and found no significant changes. So thinking about these in terms of outcomes, some patients find helpful, but again, may not be that much different than caloric restriction. What we do know is that generally targeting a healthy dietary strategy, we know that emphasizing a lot of fruits, vegetables, legumes, whole grains is important, limiting our saturated fat, limiting our sodium, and limiting our processed foods, including our sugar sweetened beverages, really is key. And it's really small changes that make a difference. For many patients, really that accountability makes a difference. So having them monitor their food intake using apps such as MyFitnessPal, Lose It, setting realistic goals. So what is your goal in 1 month? What is your goal in 3 months? And thinking about what are the other factors? How can we reduce our stress? How can we avoid or eliminate factors that contribute to eating habits? And for some patients, definitely who need maybe that extra help, you may want to refer for therapy or for behavioral support. We do have commercial weight loss programs such as Weight Watchers and Noom that can be helpful. And there are others, on the rise where patients are provided a social network. They're able to see other people who are also on that weight loss journey and really work to help them lose weight. We also should be mindful that patients, in addition to eating well, need to be incorporating exercise. We know that when we lose and when we gain, we actually can lose both fat and muscle. And it's really important to note that our metabolism is dependent on our lean muscle mass. So what I generally tell patients is, yes, I need you doing that cardio. I need you getting at least 30 minutes of movement, but I also want you incorporating some strengthening activities. That's at least 2 days per week of some form of strengthening. It can be at least 10 to 15 minutes of even just getting some cans, some dumbbells, some exercise bands, or even doing low impact yoga, Pilates. That muscle building exercise actually does really help tremendously. And so for those patients who come to me who have attempted lifestyle interventions for at least 3 to 6 months, where they've attempted eating well, they've attempted exercise, incorporating at least 30 to 60 minutes of activity daily, and they either have a BMI over 30 kilograms per meter squared or over 27 with complications. And I importantly note what those complications are: type 2 diabetes, hypertension, hyperlipidemia, sleep apnea, and heart disease. Those are the patients who do qualify for weight loss pharmacotherapy. It's important to note that these are not drugs that we just start and don't follow up. These are patients that really need close follow up. They need monitoring for their progress, their response, and the side effects. And this should be done ideally with a multidisciplinary team, including nutritionists, potentially behavioral therapists, and exercise support. So keeping that in mind. And what I've put here is an overview of what are the medications that currently are approved on the market. So we have 5 drugs here approved. I've included, and I'll talk about these briefly, and I'll highlight the ones where we have the most data, particularly in the role of liver disease. So orlistat, known as a pancreatic lipase inhibitor, developed first in the 1990s, does help patients lose weight on the average of 2 to 5%. Keep in mind there's tremendous side effects, so a lot of gas, flatulence, and really smelly, oily stools. Phentermine, which is a stimulant, marketed originally back in the 60s, is a stimulant that helps to boost metabolism, help calorie burning, can also give that boost of energy. Obviously, we have to be careful looking at anxiety, irritability, risk of heart disease, things like that. And then the GLP-1s, which I'm going to talk about in more detail. I don't want to forget about Plenity. Plenity is a hydrogel capsule or particle that you take in before you eat, which then bulk up in the stomach and create sort of a restrictive type impact where you're not able to eat as much. Again, side effects can include bloating, constipation, diarrhea. And then we have our 2 combination drugs, Qsymia, which is a combination of phentermine topiramate, extended release, and Contrave, which is naltrexone bupropion. And these 2 drugs are relatively newer, approved in the last 6 to 7 years. Both are quite effective. The Contrave more for patients who are overeating or binge eating. And so thinking about the data and what do we have, what the drug that I don't mention here, which I will, is metformin. So metformin, classically, we've used for type 2 diabetes. We've had it approved since 1994. It has a very unique mechanism. It lowers the amount of glucose production in your liver. It helps improve insulin sensitivity. And I want to be clear that this medication is something that I'm using more of, especially in these patients, because we know with weight gain, there is some impaired insulin sensitivity, resistance. And so for patients who have elevated A1Cs, pre-diabetes, or are at high risk for type 2 diabetes, these are patients that can benefit from metformin. However, metformin is not approved for weight loss at this time. So jumping ahead to the GLP-1s, so we have the first GLP-1 that was approved for weight loss is liraglutide, also known as Saxenda. So this was developed and approved in 2015 from Novo. It is an injection that you are giving yourself daily, starting at 0.6 milligrams, titrating every week to a maximum dose of 3 milligrams every day. What's key to keep in mind is there are side effects: stomach upset, nausea, potential risk of gallbladder disease, very rare risk of pancreatitis. The big point to make is that these drugs are expensive. So patients really, if they have commercial insurance, they have to have coverage for obesity drugs. And unfortunately, if they do have Medicare, Medicaid, unfortunately, those insurance plans do not cover Saxenda as a weight loss drug. I bring up the initial study when liraglutide or Saxenda got approved. So this was produced in 2015, New England Journal of Medicine. And I point out that at 56 weeks, the approximate weight loss highlighted in blue here with liraglutide up to 3.0 milligrams was on the order of 8 to 10%, which was one of the strongest drugs we had at that time. But I also want to point out at the bottom here is that almost 14 or more percent of patients lost more than 15% of their body weight. So thinking about what is that target that we're trying to achieve, these numbers are quite tremendous. And again, that's why liraglutide or Saxenda is a great drug. Jumping ahead to Wegovy, so it's sort of been superseded by Wegovy, which was approved in 2021. So keeping in mind that semaglutide, also known as Wegovy, initially approved as Ozempic for type 2 diabetes, then marketed for obesity and approved in 2021. So this is a weekly GLP-1 that we are titrating every week, every month. So we're starting at 0.25 and every month you're titrating up. So it takes about 4 months just to reach the maximum dose, which is 2.4 milligrams per week. Keeping in mind, again, what are side effects with these drugs? They do slow motility. There is risk of delayed gastric motility. There is risk of nausea, bloating, stomach upset, reflux, constipation. These are the most common side effects that we're seeing. And what I like about Wegovy is that the pen actually is very easy. It's very much like a plunger. So you press the button, it injects, you're done, you throw it out. I raise here the study again from 2021 in the New England Journal. So the magic number we saw with Saxenda, 8 to 10%, 15.6% at 68 weeks with Wegovy. So again, one of the sort of big advances here. Next, I want to point out how this might apply to our patients with liver disease. So this was actually a phase 2 study. Interestingly, they used daily semaglutide. So this is patients who are titrated with daily semaglutide, 0.1, 0.2, 0.4 milligrams compared to placebo. And these are patients with biopsy-confirmed F1, F2, or F3 fibrosis, followed over 72 weeks. And what's interesting to note is that they looked at outcomes, resolution of NASH, without worsening of liver fibrosis. And as you can see here, in terms of percentage of patients, there was some significant improvement in terms of resolution of NASH. However, when you look at improvement in liver fibrosis, comparing semaglutide at the maximum daily dose they provided of 0.4 milligrams compared to placebo, there was no significant improvement in liver fibrosis. So keeping in mind, yes, may be helpful in terms of NASH, but no significant improvement in terms of fibrosis. In a more recent study, so this was using actually true Wegovy weekly, titrated 2.4 milligrams. So this was a study in patients with NASH or MASH related cirrhosis. Mean BMI was around 35, and these were patients followed for a little bit shorter, 48 weeks. And what they found was that, as expected, semaglutide 2.4 was associated with significant weight loss, as well as improvement in lipids and body fat and other metabolic parameters, but again, keeping in mind and looking at improvement in liver fibrosis and resolution of NASH. So in terms of panel A and panel B, you can see that, again, no significant difference in terms of resolution of resolution of NASH, and keeping in mind also looking at improvement in liver fibrosis. So these are things that need to be evaluated and investigated further. What I also point out, because we also care in the setting of liver disease, looking at heart disease, the SELECT trial. So this was semaglutide 2.4 milligrams, a study that they're still preliminarily reviewing and analyzing, but they released preliminary data showing that semaglutide 2.4 does reduce the risk of major adverse cardiovascular events by 20%. And these are patients followed over 5 years. So this is really tremendous in terms of looking at the benefit, not only from liver perspective as well as cardiovascular perspective. So again, another sort of boost for the GLP-1 semaglutide. So when we think about it also, so one, we have Wegovy, we now have newer generation medications that are coming up. So here, this is actually a summary paper that I pulled, and we have the GLP-1s on the left. We now have also drugs being developed that worked on amylin. So amylin is currently approved for type 1 diabetes. They're now developing cagrilintide to help patients for weight loss. We also have oral GLP-1 agonists. So we have an oral version of semaglutide. There are other smaller molecule partial GLP-1 agonists that they're developing. We also have dual combination GLP-GIP, which I'm going to talk about, tirzepatide, as well as others coming in the pipeline. And we have now also double combinations with amylin analogs with GLP-1s and triple G, retatrutide, which is combining GLP-1, GIP, and glucagon. So tremendous drugs coming out through the pipeline, which can help us in the future. And I want to pull up some of the studies here. So this is the paper that was published in New England Journal in 2022 looking at tirzepatide for obesity. So mind you, tirzepatide or Mounjaro was approved for type 2 diabetes last fall. This is the paper that it was tested for weight loss. And these are patients without type 2 diabetes where they were randomized to doses of tirzepatide of 5, 10, 15, or 20, or placebo. And the magic number here, which I want to pull out, was that the average weight loss was 20.9% over the span of 72 weeks. So thinking about Saxenda, 8 to 10%, Semaglutide 2.4, average weight loss 15%. Now we have tirzepatide, average weight loss of 20%. So again, an increase there, which is tremendous. I also want to point out the recent SURMOUNT-2 study. This is tirzepatide now in patients with obesity and type 2 diabetes. While they don't quantify the amount of patients who had active liver disease here, I do want to point out that the numbers are similar. We do know that patients with type 2 diabetes may not respond to these drugs as strongly as those without. But if you look at the average weight loss, people did lose on average approximately 14.7% body weight at the maximum dose of tirzepatide, which is significant. And there was significant A1C reduction over the span of the trial. They said, and this is also to keep in mind, almost 1,000 participants with a mean age of 54 and a BMI of approximately 36. Jumping ahead, I mentioned briefly about retatrutide. So this was a paper recently published. So this is a triple hormone agonist looking at GLP-1, GIP, and glucagon. And the question is, what is glucagon doing? How is it helping? Is it acting on the brain? Is it acting on sort of receptors to help us sort of reduce our appetite, reduce satiety? So this is where they randomize patients to retatrutide starting at 1 milligram up to 4, or 8, or 12. And this is a phase 2 trial. So again, keeping in mind, these are patients who were randomized to drug versus placebo. And what's important to keep in mind are these numbers. So at the highest dose, retatrutide 12 milligrams was associated with 24% weight loss compared to placebo. And what I also want to keep in mind is at the bottom, we're looking at weight loss targets. So more than Actually, 100% of patients lost more than 5% of their body weight. But what I also want to mention is 26% of patients on the max dose of this drug lost more than 30% of their body weight. So really, that is tremendous, suggesting that a quarter of patients, lost, almost half or close to half of their body weight. They do mention that there were side effects as expected with these studies. There were some GI side effects, mostly mild and moderate. There was also a potential increase in heart rate that increased with the dose titration and then normalized over the course of the study. There was no significant hypoglycemia. That's also a key parameter that we want to keep an eye on, especially since we're including glucagon. And there was improvement in those patients with prediabetes who then were able to achieve normal glycemia. So another drug on the horizon that we want to talk about. Oops, sorry. For those patients who have potential type 2 diabetes, have BMIs over 35, these are patients, and concurrent liver disease, these are patients you might want to consider for bariatric surgery, or if they have a BMI over 40, these are again patients who might qualify for surgery, as many of you are aware. So for patients who may either don't have coverage for weight loss drugs or may not want them, or have concurrent comorbid conditions that might prevent them from taking some of these drugs, these are patients who you do want to consider for weight loss surgery. And majority we are doing are mostly the endoscopic, the gastric sleeve compared to the Roux-en-Y. I want to point out some of the recent literature looking at these outcomes with bariatric surgery and liver disease. So this was a study in France looking at patients with obesity who were followed for 5 years after surgery. And what they found is these patients had liver disease. At 1 in 5 years, there was significant resolution of NASH at 5 years. There was also reduction in fibrosis. They found disappearance of fibrosis in almost 56% of all subjects. So again, thinking about what is the benefits of lifestyle approaches versus medicine versus surgery in improving liver disease, clearly bariatric surgery has tremendous benefit here. I also want to mention the benefit of bariatric surgery in cardiovascular disease. So we know that liver disease, diabetes, these are all risk factors for cardiovascular disease. So this is actually a study using a market scan claims database, over 89,000 patients who had obesity and some form of MASLD were treated with bariatric surgery, and they were compared to an active group without surgery. And what they found looking at cardiovascular outcomes was that those patients who underwent surgery with active MASLD actually did better and had reduced risk of cardiovascular outcomes. In these patients, they were followed for over 21 months. And the risk reduction was almost 49%. So again, these are significant data points when we think about it. I don't want to forget the role of bariatric endoscopy. So bariatric endoscopy, looking at endoscopic sleeve gastroplasty, also the single or dual balloon. So these are interventions that are done by our gastroenterologists. They are endoscopic, they are non-invasive. At the moment, they are not covered by insurance. However, they can be effective and average weight loss on the order of 10 to 15%. So I'm hoping some of these get approved in the future by insurance. So what I sort of did in a whirlwind is sort of talking about the role of lifestyle interventions, medications, bariatric surgery, and how these can impact patients with obesity. What I want to emphasize is that we are now transitioning where we're not just focusing on a number on the patient's weight. We're not just saying you need to get to a normal BMI. We are taking into account the patient's weight, their story, their history, their exam. We're measuring their weight, their body mass index, their waist circumference, and then we're staging them based on the degree and severity of complications. That is how we need to personalize our approach. Whether we first focus on lifestyle or we jump ahead to more aggressive interventions, it really depends on the patient, their severity, and also sort of their nuances in terms of what they like and what they have a role in and what they would like. So again, keeping in mind, we're moving towards more of a complication-centric approach. I'm losing my slide here. So with that, I'm going to end here. I'm sorry, I forgot my summary slide. So I just wanted to say obesity, we know, is a chronic disease state, has multiple complications. Really, this is a stepwise approach we need to take. There is a growing interest in tremendous amount of drugs that are coming through the pipelines. We definitely need more data and more research in terms of how these drugs and how bariatric surgery fits in, especially in patients with active liver disease. And with that, I'll end there. Thank you so much.
Great. Thanks, Rashmi. So a few questions for you, no surprise. So one question is, when you look at the calorie restricted diet and you saw no impact, the question is, does the quality matter or is it just quantity? In other words, if you had a 1,600 calorie Mediterranean diet versus a 1,600 calorie, high fructose, does quality matter? Or is it just quantity?
Yeah. So I don't think we have a specific study where they've, put someone on a junk food diet, targeting 1,600 calories versus a healthy diet. I don't think we have that, but I think for sure we already know the benefits in terms of incorporating whole grains. The Mediterranean diet helps reduce cardiovascular outcomes, mortality. We have that data. So I definitely think that, yes, the focus is quantity, but also quality. I think it's both. And we see that from the outcomes, from how patients respond and also how they respond to drug therapy. So I think it's both.
And then when patients are on a GLP-1 for weight loss, and what happens when they stop?
Yeah, so there was one initial study done a few years ago where patients stopped Ozempic. They were followed for a year. Unfortunately, there was regain. There have not been any follow-up studies really looking at that, but we know for sure that anytime you provide an intervention, there is going to be a risk of regain. And so what I counsel patients is that, yes, obesity is a chronic disease. Liver, cardiovascular, these are all chronic disease states, and that once you start them, you're going to be on them. Patients don't want to hear that, obviously. So I generally say, let's start with targeting 1 year, 2 years, and then we'll come back and sort of reevaluate. But, there are certain hard stops, like if a patient tells me they want to get pregnant or if they have other comorbid reasons they have to stop, we incorporate that. But otherwise, they're going to be on these drugs for some time.
And then when you stop, do you stop abruptly? Do you taper off? What's your approach there?
So yeah, there haven't been a lot of studies with weight loss maintenance, but what I have done is either taper the dose. So again, the idea is using the lowest dose possible where they can find and achieve that benefit where they're feeling some sort of appetite suppression. There have been some challenges. Sometimes the pharmacy pushes back and says, why are you lowering this patient's drug dose? And sometimes what I've also done is extend the interval. So rather than doing like a semaglutide 2.4 every week, maybe do it every 2 weeks or maybe do it every 3 weeks. And that's sort of what we consider sort of maintenance dosing. And patients say, I feel a difference. I like this. This is only every few weeks. And these are some approaches that I've taken. But yes, I think we need more information and more studies in terms of guiding patients once they achieve their goal weight. Yes, do we taper off? What do we need? And my thought is it's really the lowest dose possible that they need to help them maintain that weight. I don't think completely coming off of it completely is really an approach we should be telling patients.
Okay. One question about pioglitazone, whether it helps in MASH.
Yeah. So the challenge with pioglitazone, at least from the weight perspective, is there is risk of fluid edema, diastolic heart failure. So I've been hesitant to use it even from the type 2 diabetes perspective because of that risk of weight gain. I will defer to you in terms of the data.
Yeah, in the Pivens trial, there was some improvement in NASH, but no improvement in fibrosis. And
Yeah.
so it's really weighed against, kind of if you're treating diabetes, if you also have diabetes and you're treating that, fine. But when you're telling patients to lose weight and then you're giving them a drug that makes them gain weight, that conversation doesn't go very well. So I would say it is good, obviously if you have a lean patient and diabetes and not has just low level fibrosis, certainly it could be tried. One last question, then we'll move on. When patients have bariatric surgery and then there's weight gain 2 to 5 years later, any role for GLP-1s in that setting?
Yeah, so there is growing literature looking at even liraglutide, Saxenda, and Wegovy in the post-bariatric space. I didn't present that data today, but definitely there is benefit. So for patients who are regaining, and that, especially we see they reach their trough at like 1 year mark, and then they unfortunately start regaining, definitely that may be a time to intervene and consider a GLP-1.
Okay. I think what we'll do is, are you going to be at the panel discussion 3?
Yeah.
So we can have some more discussions there about this because I think we want to move on to our next speaker, but there are definitely some more questions about pharmacologic intervention versus bariatrics. So we'll come back to that. Okay, thank you so much, Rashmi. Now we're going to move on to Dr. Augusto Villanueva, who's associate professor here at Mount Sinai. He's really an international expert in HCC, and we'd like to hear from him about finding a needle in a haystack, MASLD and HCC. Augusto.
Yes, thank you, Mina. It's great to be in the first NASH Center of Excellence Symposium talking about HCC in the context of patients with MASLD, which is a challenge and will be even challenging as we have more and more cases. Here you have a summary of my disclosures. And this is the agenda for my roughly 20 minutes talk. I'll talk a little bit about liver cancer and the connection between MASLD and liver cancer, and then we'll discuss something that is very interesting to me, and is the challenges that we have for HCC surveillance in the context of MASLD and in the context of chronic liver disease in general. I want to start with some numbers. So these are the data from, cancer mortality and incidence for different tumor types. And liver cancer ranks the third in terms of new cases and is the third in terms of deaths. Between stomach cancer and liver cancer, there are third and fourth changes every iterations of this statistic. But what I think is remarkable is when you look at the size of the dot in this plot tries to show the lethality of the malignancy. The most malignant tumor, the most lethal tumor, so is pancreatic cancer. The second one is liver cancer. So the median survival of overall the patients that are diagnosed with liver cancer is roughly 2 years worldwide, which is still very low. The other thing that I want to underscore is what has happened with liver cancer, even though this is starting to change, but until very recently, the numbers of liver cancer were increasing dramatically, meaning that between 2009 and 2013, even though liver cancer was not the most common malignancy or the most incident malignancy, it was the one that increased incidence faster. You have here the data of different tumor types, liver cancer for men and women, as you can see, the highest in terms of change of incidence between this period, which indicates that it's a problem that is becoming more prevalent. As you know, this has been discussed several times. It's very rare to develop HCC in the context of normal liver. So most patients with HCC have chronic liver disease, and the majority will have cirrhosis. This is the rationale to recommend surveillance in patients with cirrhosis, because between 2-3% per year will develop HCC, even though this number is slightly overestimated, particularly for MASLD-related HCC. But still, it's a high risk of HCC development in the context of cirrhosis. Now, there are some patients that may develop HCC without cirrhosis. This is very well known for hepatitis B, but there are some patients with MASLD and with hepatitis C that can also develop HCC without cirrhosis. And this is a problem because these patients, since they don't have cirrhosis, they're not enrolled in surveillance programs. So the likelihood of these patients being diagnosed at a more advanced stage is higher. And what has been the impact of MASLD in terms of HCC incidence? As you can see here, this is data from Newcastle, which is Northern England. This is the number of HCCs being discussed in their tumor board between 2000 and 2010. As you can see, a steady increase in the number of cases that they were seeing. But the bars, the color of the bar represent the etiology of the underlying liver disease for the HCCs that were discussed. And in particular, the orange bar is the MASLD related HCC, which increases steadily, reaching roughly 30% of the cases at the end of the study. So 30% of the HCCs in Newcastle are related to NAFLD. And if you look at the clinical features, so they compare a number of clinical characteristics of the HCCs related to NAFLD, alcohol use disorder, hepatitis C, and hepatitis B. And what they found is that the patients with MASLD HCC tend to be heavier and tend to be older. Heavier makes sense because they have metabolic syndrome, they're more obese, etc. The other thing that they found is that all of them, actually, in their study, they all have metabolic risk factors, which also makes sense. But what's striking is that the percentage of patients with HCC without cirrhosis was significantly higher among patients with MASLD compared to patients with alcohol. None of them were non-cirrhotics, or hepatitis C or hepatitis B, suggesting, as we all know, that you can develop HCC even in the absence of cirrhosis if you have MASLD. The liver function of these patients was tended to be a little bit better also, which reflects the fact that a significant proportion of them were non-cirrhotics. Now, despite we know that you can have an HCC without cirrhosis in the context of MASLD, what is very difficult is to estimate the exact risk. So what is your individual risk if you don't have cirrhosis or develop an HCC? So I'm going to show you two studies that address this issue in different ways and provide complementary information. So this is a study, a retrospective study from the VA. Hashem El-Sarraj was the PI of this study. Huge study, 600,000 subjects enrolled, retrospective study with a significant number of events. So a significant number of HCC developed during this time was around 600. As you can see here, very clear separation of risk of HCC if you have NAFLD compared to the controls. Now, when you look at the data with a little bit more detail, you start to notice that actually what drives the risk in this study was those patients with cirrhosis, and particularly those patients with cirrhosis and a high FIB-4 score, with an incidence rate of 13.1 cases per 1,000 person year. So again, despite you can develop HCC in the absence of cirrhosis, the risk if you don't have cirrhosis is significantly lower than if you have cirrhosis. And this is a second study that Scott mentioned at 8 this morning. Is a prospective study. The beauty of this study is that you have a baseline biopsy of everybody. So not so many patients, well, 1,700 subjects is a very reasonable number when you think that all of them have baseline biopsy. So you know the status of the liver at baseline, and then you follow the patients. The median follow-up was between 3 to 4 years, and you check for events, and you see, talking about HCC, that the patients with F3 and F4 are the ones developing HCC. Again, the numbers are relatively small, so you cannot derive strong conclusions, but what is clear and connects with the previous study is that the key factor is advanced fibrosis. And I'm struggling by the F3. It's a little bit higher, and we can talk about where the biopsy, sampling error, whatever. But what's interesting is that the F3 captured the signal mostly for risk of HCC in patients with MASLD, but without cirrhosis. There's some genetic predisposition for HCC in the context of MASLD. You heard about the PNPLA3 genotype, which is very strong. It's been shown in multiple studies, not only associated with MASLD, but also associated with HCC in the context of MASLD. This is a study also from the UK, a rather small study. It's been heavily criticized for a number of issues, but still very strong association. And there was a meta-analysis published shortly after this study that demonstrates or confirms the association between PNLP3 and HCC development in patients with MASLD. Now let's move to the second part of the talk, which is the challenges of HCC surveillance. As I mentioned before, cirrhosis is a risk factor for HCC, and that's a rationale to recommend all patients with cirrhosis to undergo surveillance with ultrasound AFP every 6 months. But I want to give you some specific numbers of what this represents in the US. So there are approximately 600,000 cirrhotics in the United States, and we assume that between 2 and 3% will develop an HCC every year. We have 30,000 new HCCs per year. As I mentioned before, the performance of ultrasound and AFP for the early detection of HCC has a sensitivity of 63%. This is what is recommended in guidelines. It's not very good. I would say it's rather suboptimal, but it's what is recommended, what we have. So with ultrasound and AFP, we detect 63% of our early stage HCC cases. So we have roughly 40% of the cases, 11,000 patients that are not detected just because the tools that we use are not good enough for the detection of HCC. But this is on the ideal scenario that everybody at risk is enrolled in a surveillance program, which is not the case, and actually is rather low. Only 25% of the patients who should be on surveillance are actually enrolled in a surveillance program. So if we compute that in this plot, the majority of the patients are not detected because they're just not on surveillance. Now, out of the ones that are on surveillance, the sensitivity of ultrasound AFP is 63%. So of the total number of patients, we only detect 15%. We have a staggering 85% of patients that are not detected, either because the tool is just not good enough or because the patient is not enrolled in surveillance. So in practical terms, if you want to increase the number of patients detected at early stages, you need to do two things. You need a better tool, something that increases the sensitivity from 63 to ideally 100%, but at least 80%. And you need to increase implementation. You need to increase that 25% to 40, 60, 80%, so that we can detect more patients because there are more patients enrolled in surveillance programs. And I have to say that the study of the 25% of implementation was published in 2020, but there was a previous study published 5 years ago, 5 years prior to that study, that showed the same number. So we haven't improved practically nothing in terms of HCC surveillance implementation. So then I did this exercise. So you can improve the tool or you can improve the implementation. What's better? So it's better if we improve the tool or if we improve the implementation. So here is this kind of a mental exercise trying to show this. Here I'm showing the percentage of HCC detected, and here is the improvement either in the test or in the utilization. Let me show you an example. It's easy to understand. These are benchmark. This is where we stand. We detect 15% of the patients because we use a tool that has a sensitivity of 63% and a utilization rate of 25%. Now let's say that we have the perfect tool, fantastic method to detect HCC with a sensitivity of 100%. Fantastic tool. Now, since we only have a 25% utilization, we still are going to detect only 25% of the patients. But let's say that we have the same tool, we continue to use ultrasound AFP, but we increase implementation. Instead of 25%, we have 63% implementation. Now the number of HCCs detected increases to almost 40%. And what if we have a little bit of both? So we have a better tool, not an outstanding tool, but a better tool with a sensitivity of 82%. And we increase implementation, not to 63%, but from 25 to 36. We reach almost the rate of a significant higher implementation. The bottom line and the message I want to deliver is that a lot of us are very interested in developing new tools for early detection. A factor that is as important as that is to increase implementation rate, to have more patients enrolled in surveillance. And that's how we're going to detect or identify more cases at early stages. And I was Yeah, I'm still a little bit puzzled by the fact that only 25% of cirrhotic patients are enrolled in surveillance programs. And I thought, so what's, in terms of the big picture, what is the surveillance rate for other malignancies, for other tumor types? And I know that, you cannot compare directly HCC surveillance with, breast cancer screening or cervical or colorectal or prostate. There are different malignancies, different methods, different tests. So it's not the same. But I want to just compare the percentage of individuals that are up to date with surveillance. For HCC, as I told you before, is 25%. For prostate cancer, is 40%. So not ideal, but still much better than in HCC. For colorectal, cervical, and breast cancer, is in the range of 70 to 80%, significantly higher than HCC. And why is that? So I thought, well, maybe one of the reasons is because the risk of breast cancer or colorectal cancer is just higher than the risk of HCC. So we look at the numbers. This is data from the SEER database. We have here different tumor types. And what I'm showing here is the lifetime risk of an individual of developing any of these malignancies. So this is data for men. So the lifetime risk of a man developing prostate cancer is 12%, which is relatively high. The lifetime risk of a woman developing breast cancer is 12%, so it's also relatively high. And the risk of liver cancer is relatively low, it's 1%. But we're not talking about population risk of HCC, we're talking about risk of HCC among cirrhotics. So if you try to see which is the lifetime individual risk of a cirrhotic patient developing HCC, it's not easy to get that data, but there are some studies that show that this is in the range of close to 30% for men and 7% for women, which is 3 times higher than the risk of prostate in men and breast in women. My point being that it's not risk what determines the social contract that makes people go for their colorectal or their breast surveillance, and for cirrhotic patients not being surveyed in a similar manner. I think it's something that needs to be addressed. Now, in terms of MASLD and ultrasound and AFP, we have an additional problem, is that, as you know, most patients with MASLD cirrhosis, they are obese, they have metabolic syndrome, so the quality of the ultrasound is lower in general. This was quantified by a study done by team of Amit Singhal in Dallas. And they just quantified so when you order an ultrasound, you get a measurement of the quality of that ultrasound. It had nothing to do with the detection, it's just the quality, if the quality of the procedure was good enough to assess adequately the liver. So in 20% of the ultrasounds that they reviewed, the ultrasound was likely or definitively inadequate for a good evaluation of the liver. And they look at the factors associated with poor ultrasound quality. And the strongest factors were sex, was high Child-Pugh, and the strongest by far, as you can see here by the odds ratio of 8, was BMI. And it was a scaling with BMI. So the higher the BMI, the higher the association with poor quality. So in addition to ultrasound and AFP being not good, in MASLD HCC, they're even worse because the performance is not so good. So that's why we got interested in developing new technologies that will not only increase the performance of the tool, so it's not something that is better at diagnosing HCC, but would eventually simplify the whole surveillance program. If you think about it, here in New York, it's not a big issue, but in rural areas, patients have to go every 6 months to a tertiary center to get the ultrasound done. And after a couple of years, patients get tired of doing that. And there's some attrition, particularly in rural areas. It would be great to have an alternative method, easier and ideally more accurate, to implement HCC surveillance. So we get interested in liquid biopsy, which is essentially the analysis of tumor components, either the cells that are released to the bloodstream, or exosomes, which are small vesicles released by the tumor cells, or fragments of DNA that are released to the bloodstream. Essentially, with a blood test, you can access tumor components, and that's very convenient, not only for HCC surveillance, but for diagnosis, prognosis prediction. As you know, liquid biopsy is all over the place in oncology, and it's becoming mainstream in terms of monitoring disease. And the different components that you can analyze in liquid biopsy, the DNA, the vesicles, and the CTCs, the circulating tumor cells, provide different type of information. So you can also analyze the different compartments and get complementary information. So we got interested in vesicles, and we did a study on the potential role of small vesicles for early HCC detection. So we isolated, we took blood from patients, do ultracentrifugation, 2 rounds, and we isolated the vesicles and did RNA sequencing on the vesicles. We confirmed first that we were isolating the vesicles. There's a number of technologies to make sure that your target is actually what you're enriching for. We found that there's 3 small RNAs that are significantly overexpressed in the vesicles of HCC patients compared to controls. A case control is a biomarker phase 2 case control study. And I want to point out that all of our HCC, the ones that we enrolled in the study, had early stage HCC, because at the end of the day, this is the target for surveillance. We don't want to detect more HCC. We want to detect more HCC at early stages so that we can change the natural history of the disease. We can improve cancer-related survival, which is the aim of any surveillance program. And this is the performance of our method. This is the predicted performance of ultrasound AFP. As you know, 63% sensitivity, 83% specificity. This is the performance of AFP in our cohort. In orange, you have the performance of our 3 markers. And here at the top, you have the performance of combining our 3 markers with AFP. Sensitivity of 86%. Again, it's not 100%, it's not the perfect biomarker, but it will help improve numbers if we make the whole process easy. And a specificity of 90%. Again, we're talking about a blood-only biomarker. This would theoretically remove the need for an ultrasound as part of the whole surveillance process. And finally, I just want to let you know that we here at Sinai recently created the New York City Translational Research Center for Liver Cancer Surveillance, which is funded by the NCI. It's 4 institutions here at Sinai. We lead it here at Sinai, but it's also Montefiore, Columbia, Cornell, and we have a company that will aim at defining the role of liquid biopsy for early detection of HCC. We're very excited. We're also doing radiomics, so hopefully we'll provide new data that will facilitate the whole process and increase the number of HCC detected at early stages. So in conclusion, MASLD is the fastest increasing cause of HCC in Western countries. We know that HCC can develop in MASLD without cirrhosis. The magnitude of the risk is still unclear, but it's likely very low, and we don't know who are these patients. So early detection is suboptimal for HCC, and we definitely need to risk stratify the patients with MASLD, particularly those with F3 that are at high risk of HCC development that we're still not able to identify. There's no question that HCC surveillance is recommended in MASLD cirrhosis, and that I think that liquid biopsy is a very promising technology that could improve HCC surveillance by having a more accurate tool, but also by facilitating the whole process of surveillance and increased implementation. And with that, I'm happy to take any questions.
Great. Augusta, are you doing HCC surveillance in the F3 fibrotics?
Yes. And the reason for that is, so even with biopsy, is how can you be 100% sure that the patient is F3 and not F4, right? Early F4. So given that uncertainty, until we have stronger markers that would tell us what for sure, you know, F2, F3 are those that are F3, F4, I think the best is to do surveillance in these patients, yeah.
Okay, great. All right, thanks so much, Augusta. I'm sure there's going to also be more. One quick question. Does early detection improve prognosis?
Yes. So there is no randomized control trial that demonstrates that surveillance increases survival in HCC, and that's the reason why it's not included probably in the USPSC task force. But there is a lot of cohort studies, retrospective data that show that if patients are enrolled in surveillance and they comply with surveillance, they live longer. So yes, it has an impact in prognosis.
Okay, great. So we will move on. I hope you'll join the panel discussion. There may be some additional questions. And in the meantime, I'm going to move on to our next speaker, Dr. Stephen Harrison, who's been the principal investigator on many of the NASH therapeutic trials. And he's going to share with us kind of where we are now. He's the medical director of Pinnacle Clinical Research and the president of Summit Clinical Research. And can I get a drum roll, please?
Thanks, Mina. All right. Well, it sounds like there's an absolute all-star lineup today. I'm just happy to be part of the team for your first annual Mount Sinai Symposium on MASLD and MASH. So thank you for this opportunity to take a few minutes and talk to you about approved and emerging therapies for NASH or otherwise MASH, otherwise known as NASH. So without further ado, I'll jump right in. And I think you have to start with where we are with the epidemiology of this disease. You may have already been over this a bit today, but just from my perspective in talking to patients, this idea that the disease is really an epidemic, a pandemic, is something that I have to communicate to my patients every time I'm in clinic. And just to share with them the fact that, a third of our patient population has fatty liver, half, if not 2/3 of our diabetic population has fatty liver. And then when we stick a needle in their livers, ranging from 5 to 14%, I'll show you some data in the next slide or two, speaking to how common I think this disease really is. But in the diabetics, the story is very, very clear. 50 to 70% have fatty liver, 35 to 37% have NASH, and 17% of that population has advanced liver disease, at least according to Yonassi's publication in 2019. So if this is such a major problem, where are we at with drug development? Well, there are no approved treatments currently available, and this is, heading towards the end of 2023. I've been studying NASH since the turn of the century, since you and I were in fellowship. I know that dated us a little bit, but suffice it to say, we've been struggling for almost a quarter century to try to find an appropriate treatment for our patients. And more sobering than what I've shown you already is the fact that really the predictions are that this is going to continue to grow. It is projected to almost double from 2015 to 2030. And if you look at Medicare, Medicaid patients, it is the number one reason for transplantation currently, and that is expected to continue to rise. I want to just highlight this study. It's one we published in 2021 because it is the only prospective prevalence study ever done looking at MASLD and MASH and using liver biopsy. We studied a group of patients that presented for routine colon cancer screening. They were there to find out their colon health, not that they needed a colonoscopy for any particular indication. It's just that they had reached a certain age. And so our mean age of our population was just a bit over 50. And we enrolled 664 of these patients. When they came in, we asked them, would you like to know your liver health? And we excluded them if they had underlying histories of liver disease, fatty liver, meds that caused fatty liver, or alcohol intake. We used MRI proton density fat fraction to define the prevalence of fatty liver. And I used MR elastography and multiparametric MRI, as well as FibroScan and CAP, to characterize these patients. If any of those tests were in the abnormal range, I offered a liver biopsy. And so what is shown in the dark blue is the prevalence by MRI PDFF of the various types of patients in the demographics. So 38% fatty liver, again, middle-aged cohort of Americans, at least in Texas, presenting for colon cancer screening. more common in males than females. We know that already. More common in Latino, Hispanic, almost half, a little more than half had fatty liver. And of course, the diabetic data is similar to what I showed you from Zobario-Nasi, 70% having fatty liver. In the magenta color, we see MASH. This is liver biopsy defined. The prevalence was 14%. It's likely higher than that because we had quite a few patients who declined liver biopsy, even though they were at high risk based on non-invasive tests. The highest risk group, way over to the right, you have metabolic syndrome. 3/4 have fatty liver and almost half have NASH. And just to put this in perspective, we did the same trial about 8 years earlier from 2007 to 2010. And it was about 300 patients or so. And there we saw the prevalence of NASH or MASH to be around 12%, growing to 14% over that 8-year time period. So not a ton of difference. Where we saw the biggest difference was in those patients presenting with F2 to F4 disease. And remember, these were completely asymptomatic patients. They thought their livers were completely healthy when we enrolled them into this trial. And just to give you perspective, that's a 119% increase in the prevalence of advanced liver disease over this 8-year time period. And this represents about 1,000 patients prospectively studied and liver biopsied. So I think this is significant. It is growing, and it's consistent with the papers that were published previously, looking at what was likely to happen with this disease over time. And we're seeing this play out in real life. Just to add to that, this disease walks hand in hand with diabetes. That you could argue that it's the diabetic, it's basically diabetic hepatopathy, just like we worry about retinopathy, neuropathy, and nephropathy. We should be worrying about the fourth major complication of diabetes, which is liver disease. So just to give you a flavor of what the Centers for Disease Control show on their website relative to the prevalence and disease burden of diabetes, the darker the area, the higher the prevalence. And you can see from 2004 to 2019 that the majority of the US has significantly increased the prevalence of diabetes, consistent with what we're seeing in the prevalence of NASH rising as well. So now we've talked a little bit about the burden of disease. Now I think we should point to, once you have disease, what does that mean for you from a liver health perspective and just from a general well-being perspective? And what we realize is the more fibrosis, the worse the prognosis. Obviously worse at F4 or cirrhosis, but starting to build at F2 disease. And I think this is the main reason why the FDA looks at F2 and greater as the population to study in drug development trials. Now, we'll get to that in a minute, what the FDA is looking for conditional approval. But I think it's important to look at this study. So this is a collection of about 1,100 patients that had cirrhosis due to MASH from the STELLAR-4 trial and the Symposium study. So these were two very large studies with pharmacotherapy agents that Gilead was studying to treat this disease, and both studies were negative. However, negative studies, you'll hear me say this a couple times in the presentation, FAIL stands for first attempt in learning. So just because something fails doesn't mean we don't learn from it. And just because these two trials failed to hit their primary endpoint didn't mean that there wasn't learnings to be had. And we learned a ton from these two trials. Here we see that if you had improvement in fibrosis, there was actually a significant reduction in liver-related events. So this gives us the first clue that reducing scar tissue in the liver actually has implications on how patients feel, function, and survive. Parenthetically, we can't say the same thing for NASH resolution, which is the other approvable endpoint, but it's clear that we can for fibrosis regression, at least from cirrhosis to less than cirrhosis. So in the absence of FDA-approved therapy, what do? Well, I think today we take a patient-centered approach. We're targeting overweight and obese subjects. I'll speak specifically about kind of how we approach that in the next slide, but we want to focus on that. I saw a clinic yesterday, and I think I had 12 patients that actually had on GLP-1s, looking for, weight loss, trying to achieve a 10% weight loss or greater. Also, exercise. We don't talk about exercise specifically, the types of exercise as much as I would like to see. I think this study is an incredible meta-analysis that looks at about 250,000 patients that were followed for around 7 years, just looking at step count. And I have historically told my patients I would like for them to walk about 8,000 steps a day. That's usually, a huge incremental increase for my patients. So I try to get them to make marginal improvements each time they see me. But this study points to the fact that for every 1,000 step increment, there's a 15% reduction in all-cause mortality and a 7% reduction in CV mortality, all the way up to almost 12,000 steps. So if you want to set a target, just realize that 12,000 is a lofty goal, but look, at 3,000, 5,000, there's an incremental benefit. We need to talk about cutting the alcohol. And in Texas, I've learned I can't just ask them to decrease. I have to actually ask them to stop alcohol, because if you give them an inch, they take a mile. Cutting out smoking, cutting out marijuana use, that's critical. Cutting out high fructose containing soft drinks. Sweet tea is big in Texas. Everybody loves their sweet tea. We got to cut that out. And the more coffee you drink, I think the better it is. This is not decaf, it's regular coffee, as long as there's not hypertension issues or atrial fibrillation. And then treating the comorbidities, I mentioned GLP-1 use, but also looking at pioglitazone or other insulin sensitizers like SGLT2 inhibitors. Not that it necessarily helps the NASH, although we know pioglitazone actually has shown benefit. And then hitting dyslipidemia, hypertension, and sleep apnea. One little pearl for you on dyslipidemia: if you put your patients on statins and you're following patients at risk for NASH using FIB-4, just remember the FIB-4 could be falsely low because statins lower ALT and AST. There's no evidence that they actually help steatohepatitis, however, but they do lower liver chemistry test. So what about just summarizing lifestyle? Caloric intake reduction, usually 750 to 1,000 kcal a day, has impacts on insulin sensitivity and reducing hepatic steatosis. We want to limit consumption of fructose-enriched beverages. I will say this: it does appear that whether you follow Mediterranean diet or you follow intermittent fasting, there is some benefit to both of those. In fact, recent studies have shown if you can fast 1 day a week for more than 24 hours, you actually improve autophagy, which is critical in this disease as well. So weight loss goals around 10% if you can get it. I talked about exercise already, and then cutting out the alcohol. So what about things that we can do to help our patients beyond lifestyle? I just want to talk about bariatric surgery, GLP-1 use, and pioglitazone before I move into the future therapies in development. This is just a slide that's been shown around the world numerous times, looking at bariatric surgery, and this is in severely obese patients with MASH. And you can see pre-surgery, that magenta colored piece of pie is severe inflammation, the dark blue is moderate, and the light blue is mild. The very, very light blue you see in the middle circle and the right circle is no NASH. Obviously, the 180 patients pre-surgery all had NASH. And you can see over 5 years, what happened was an 84% resolution of MASH. None of those patients had worsening in fibrosis, which I find interesting that that's actually included in Subpart H approval that you have to have MASH resolution without worsening of fibrosis, because it's very unlikely to have worsening of fibrosis in the setting of resolution of inflammation and ballooning and steatosis. That resulted actually in improvement in fibrosis in about 70% of patients that were followed out to 5 years. It is also important to note that fibrosis didn't improve in 70% of patients immediately after NASH resolution. This actually took a while to see that downstream impact on fibrosis, and also significant reductions in liver chemistry tests and insulin sensitivity that went along with that. So we mentioned earlier GLP-1 use, and I think it's just important to briefly highlight how that might help our patients with fatty liver. And you just see here a cartoon illustrating that GLP-1 receptor agonists work to not only lower liver lipids, but also adipocyte secretion of fatty acids that come into the liver and cause lipotoxic stress and upregulation of pro-inflammatory mediators that ultimately drive what we see under the microscope as steatohepatitis. So this drug has pleiotropic effects on weight loss and improving insulin sensitivity. So this drug is approved for obesity. It's also approved for diabetes in the US. And there has been a large phase 2B trial in NASH led by Phil Newsom and colleagues that was published in the New England Journal in 2021. This was a rather large study of over 200 patients treated for 72 weeks. You had to have a biopsy to get in showing NASH and fibrosis, and then a biopsy to get out. The primary endpoint was MASH resolution with no worsening of fibrosis, and you see a relatively nice response. I would say actually a very good response. There's not a dose-response relationship. That's why I say relative. It seems like the lower two doses are about the same, and then you get a bump up with the 0.4 milligram of semaglutide. But relative to placebo, 42% treatment effect delta. So we think this drug is very good for NASH, and it's moved on to phase 3. So the Essence trial is a phase 3 trial. It's enrolled over 900 patients. Treatment is for 72 weeks again, and that is one thing we'll talk about as we move into emerging therapies. For fibrosis, there is not a response. There's a lot of discussion as to why. You see here a 43% for high dose, 33% for placebo. There's been discussions that this is an inordinately high placebo rate of response, and that's why there's not significance. I think it's more than that. I think maybe the treatment wasn't long enough with the GLP-1. There are no GLP-1 receptors in the liver. All the action is vicarious. We saw with bariatric surgery, this does take a while to get fibrosis improvement. So I think longer treatment may give us fibrosis benefit with GLP-1s. It's yet to be determined if the GLP-1 combos with GLP-GIPs or GLP glucagons or the triple Gs will have an impact, because obviously there are glucagon receptors in the liver, et cetera. So maybe that additive benefit will be helpful on fibrosis. What about other extrahepatic benefits of GLP-1? Well, there is glycemic control for our diabetic patients. There is impacts on body weight. There's new data suggesting a reduction in MACE outcomes, and there's also potential benefit on underlying kidney disease. So it's something to keep in mind as we tackle our patients' dysregulated energy metabolism and focus not just on the liver, but outside the liver as well. How about safety? Well, overall, it's well tolerated. There are some GI-related adverse events that seem to be mitigated if you start low and titrate. If you start low and titrate slowly. The one issue I have with this is an area that I think deserves special attention, and that is sarcopenia. There is some controversial literature to suggest that up to 30% of the weight loss that's occurring in these patients is lean muscle mass loss. If that is true, I worry about this being used in cirrhotic patients and our elderly patients that are prone to fall risk. Moving on quickly to pioglitazone, I just have one slide here showing all the trials that have been done with pio, showing improvements across the board, really in steatohepatitis. It's a little bit of a mixed bag on fibrosis, however. So moving forward into the regulatory framework for drug approval, there is full approval, which is based on how a patient feels, function, or survives major adverse liver outcomes. Then there's conditional approval, which is based on a surrogate endpoint reasonably likely to predict clinical benefit. And right now, that surrogate endpoint in the US is MASH resolution with no worsening of fibrosis, or at least one stage fibrosis improvement with no worsening of MASH. The EMA actually requires both. So just quickly showing you kind of my climb the hill, if you will, on MASH drug development. We've come a long way. We currently have a number of drugs enrolling in phase 2. We have a number of drugs almost finished with phase 2. We have several drugs now that have actually made it through phase 2. PXL065, I'll highlight in a moment, is not moving forward currently into phase 3. Pegozafermin and FGF21 is. Unfortunately, we've had many drugs that have failed. And again, we've learned from those failures and we've applied them to the next round of drugs being developed. Making it into phase 3, we now have 3 drugs. Semaglutide, I mentioned, the GLP-1 receptor agonist. Lanifibranor is a pan-PPAR oral drug, efruxifermin and FGF21. And then there was a beta-cholic acid that tried twice to get to the top of the hill. Unfortunately, it did not make it. That's an FXR agonist. And now resmetirom is submitted its NDA and it has been granted priority review with a PDUFA date of March the 14th. So I want to talk a little bit about some of these in more detail. Resmetirom is a thyroid hormone receptor beta agonist that really is involved in hepatic lipid metabolism. It increases lipophagy and beta oxidation. It also enhances mitophagy. So just imagine you're getting rid of the old 57 Chevy mitochondria and replacing them with brand new Ferrari mitochondria. So your metabolism is picking up, you're burning more fat, you're able to get rid of the fat that's in the liver. And in addition to that, we're reducing reactive oxygen species and ultimately inflammation and also lowering cholesterol levels. So another way to think about fatty liver is it's relatively hypothyroid. It cannot convert T4 to T3 effectively or efficiently. So you get a buildup of reverse T3, and that associates and correlates nicely to inflammation. So this resets the system and allows the liver to convert T4 to T3 appropriately. So how is it worked out? Well, just to set the stage before I show you the results, there are 4 phase 3 trials that have been done. So a large number of data has been collected. There's kind of a real world trial, which is called Maestro NAFLD-1. All non-invasive, no biopsies were done. We used non-invasive tests to get into the trial. We looked at safety and tolerability as the primary endpoint, dosed over 1,200 people, followed them for a year. That data is pending publication in Nature Medicine soon. There's the Maestro NAFLD open label trial where we took those same 1,200 people and offered them rollover into another 52 weeks of treatment. 700 patients are enrolled in that trial. And then there's the registration trial for Subpart H approval. I'll show you in a moment. There is an outcome portion to that trial. Patients are followed for a total of 54 months to outcomes. And there's currently enrolling a well-compensated NASH cirrhosis cohort of around 700 patients. This is event-driven, looking at decompensated disease. So this gives a large number of patients at both the top dose as well as the 80 milligram dose to support accelerated approval. This is the study paradigm for the Maestro NASH trial that enrolled more than 1,000 patients. 966 were included in the interim 52-week analysis, 2 doses of drug versus placebo. The dual endpoint was MASH resolution. You see the definition there that also included a 2-point reduction in the NAFLD activity score, no worsening of fibrosis, or at least 1 stage improvement in fibrosis with no worsening of the NAFLD activity score. This is an oral, once daily drug. Again, the treatment trial was 52 weeks long. You see the results here, dose responsive, 20% treatment effect delta, looking at high dose compared to placebo. For fibrosis improvement, again, a dose response, although closer in results between low and high, 26% versus 14, or a 12% treatment effect delta, both significant, however. There was also a key secondary endpoint of the atherogenic lipid LDL cholesterol. Here you see lowering of around 14 or 16% with low and high dose respectively. What about safety? Overall, this drug was well tolerated. There was mild to moderate GI symptoms of nausea and diarrhea. These tended to be self-limited and occurring in the first 12 weeks of treatment. There was minimal reduction in prohormone-free T4, no effect on active hormone-free T3 or TSH. Moving quickly to lanifibranor, this is a pan-PPAR alpha gamma delta agonist. In phase 2 trial published recently in the New England Journal of Medicine, this pill was given once daily. It's oral. The treatment was only 24 weeks. There was a 2-point reduction in the SAF score with no worsening of fibrosis that was significant at the high dose relative to placebo, a 22% treatment effect delta, and the 1,200 milligram dose has moved forward into phase 3. For fibrosis improvement, there was also significance at the high dose, 42% versus 24%. Looking at both MASH resolution and fibrosis improvement, very encouraging here for both doses, but particularly for the high dose, 45% versus 19%. There were also additional benefits on lipids and glycemic control, as you see here. As far as safety, again, overall well tolerated. There were similar nausea and diarrhea events. There are some PPAR-related side effects of pitting edema, gaining weight, and anemia that are going to have to be followed closely in phase 3. Again, the treatment duration is 3 times longer, and the high dose is the dose being carried forward. So very positive efficacy data. We have to just follow the adverse event profile. Now, another very potent drug in this disease state is the FGF21s, and this is an endogenous metabolic hormone that regulates energy expenditure, glucose and lipid metabolism. It's been shown to reduce liver fat. It has implications in the periphery at the adipocyte level and the muscle level, as well as in the liver. This just to show one particular drug in development, efruxifermin. This is given sub-Q week. This is the phase 2b trial called the Harmony trial. Patients were treated for 24 weeks. Liver biopsy primary endpoint was fibrosis improvement with no worsening of MASH. You see both doses significant relative to placebo with a 21% treatment effect delta. For MASH resolution, even better, probably industry leading, 76% versus 15%, or a 61% treatment effect delta for high to low dose. Looking at both MASH resolution and fibrosis improvement, a 36% treatment effect delta with the high dose. There are additional benefits again with the FGF21 class on lipids and glycemic control, and modest weight reduction is present in this population, despite the fact that some people actually increase their appetite. There also is implications that this drug could lower alcohol craving. When we look at those patients that were treated that had cirrhosis, there's a small 16-week trial with 50 milligram versus placebo. And you see here around 1/3 of those patients actually had regression of fibrosis. So just to say, there is a very large phase 2b trial in 180 patients called the Symmetry study. The primary endpoint is a repeat liver biopsy in these cirrhotic patients at 36 weeks, and we're expecting that readout this month. The trial is actually a 2-year study where liver biopsies will be repeated at the end of 2 years. This is just the first biopsy report at 36 weeks. From a safety perspective, again, overall well tolerated. You'll see a theme here. Nausea and diarrhea tend to be more common. The last drug that I want to show in this class is pegozafermin, very similar. It's a same mechanism, FGF21. This is pegylated, so it's slightly different in its chemical structure, but there were positive implications again on MASH resolution on the left and fibrosis improvement on the right. I mentioned very quickly PXL065. This is a deuterated stabilized single stereoisomer that essentially tries to accentuate the positive impacts of pioglitazone without the side effects of pioglitazone. And results were promising for fibrosis, did not work on NASH resolution. And unfortunately, this is not moving forward right now in phase 3. So just to summarize my last slide here, is my perspective on non-cirrhotic NASH. You see the drugs in phase 3 listed: resmetirom, lanifibranor, semaglutide, efruxifermin, and then drugs with phase 2 biopsy results, that PXL065 and pegozafermin. And I highlight their safety and tolerability. They're all generally safe and well tolerated. The ones in orange have maybe slightly higher GI-related or other issues that we have to be cognizant of. As far as the 4 areas I'm targeting for improvement, I'm looking at liver, NASH resolution, fibrosis improvement, and then also insulin sensitivity and lipid benefits. Looks like resmetirom is going to help us with 3 out of those 4, everything but insulin sensitivity. Lanifibranor, all 4 are going to be hit. The issue there is the weight gain. Is that going to be an issue moving forward? Semaglutide, the GLP-1s, work on insulin sensitivity and NASH, but no data to date to show fibrosis benefit or a lipid benefit. The FGF21s of efruxifermin and pegozafermin should do all 4 of these as well, so very promising there. And then the PXL drug I mentioned impacts on insulin sensitivity. Remember, it's pioglitazone-like, with supposedly without the side effects, hitting on fibrosis but not NASH resolution. So with that, let me conclude and say, Mina, thank you so much for the opportunity to be a part of your fabulous program today.
No, thank you. That was a tour de force. So a couple of really quick questions. Any impact of GLP-1 on fertility? I don't think so.
No, not that I'm aware of.
Okay. And then I think there's a question about inflammatory markers correlating with disease activity or progression or regression of MASH. Any other inflammatory markers in the serum that have been evaluated that correlate with MASH resolution?
So that's a great question, actually, because outside of ALT, AST, we have very few markers to actually correlate with inflammation change. You know, there's multiparametric MRI or CT1, corrected T1, that we use for those purposes in clinical trials. But as far as biomarkers for that go, kind of limited. We're actually better on the fibrosis side with some of those biomarkers.
And has the FDA granted Pegoza breakthrough therapy for NASH?
I believe so. Breakthrough, yes.
Yeah. And then lastly, I think there's a question about hypothyroidism. Just keep in mind that resmetirom is liver selective and is a thyroid hormone beta agonist. So it's really targeting intrahepatic hypothyroidism. And I think your question, Amit, about the conversion. The other thing that's happening in the liver with injury is the deiodinase enzymes that convert T4 to active T3. There is some dysregulation there. So if you just gave Synthroid, for example, you would still be diverting more of the T4 to reverse T3 rather than active T3. And so it's really the thyroid hormone beta receptor agonism that's causing the effect. Would you agree, Stephen? Anything?
Yeah, absolutely. You said that very elegantly.
Okay. All right. So in the interest of time now, thank you so much, Stephen. I don't know if you'll be able to join our panel at 3, but if you can, that's wonderful. If not, understand. And we're going to move on to our last speaker, last but not least for sure, Dr. Kathleen Corey, who is Associate Professor of Medicine and Director of the Mass General Fatty Liver Program. And she's going to talk about cardiovascular disease risk in MASLD and MASH. And Kathleen, there's been a lot of questions about statins. I'm sure you're going to address it, but just to put a pin on statin use in liver disease, because we love it.
Absolutely, absolutely. Certainly, lot of myths going around there about statins, and something we in NAFLD really, or MAFLD MASH, think is really important. So thanks so much for having me. It's a pleasure to be here today. I'm going to talk about cardiometabolic risk in MAFLD and MASH. And just of note, some of the data that I'm presenting will be in our older terminology of NAFLD and NASH. So please excuse me if I go back and forth between the terminology. We know that cardiometabolic disease is associated with MASH and MAFLD. We often think about diabetes, hypertension, dyslipidemia as being risk factors for NASH, but it's really important to remember that MAFLD and MASH can be independent risk factors for the development of diabetes and hypertension and dyslipidemia, the metabolic syndrome, and cardiovascular disease. And just to point out a few things, there is a large meta-analysis that was published of 19 observational studies with almost 300,000 patients. And these are patients with NAFLD, at the terminology at the time, who did not have diabetes and who were followed over about 5 years. And those who had NAFLD had a greater risk of diabetes than those without NAFLD, and those with NASH had an even higher risk of developing incident diabetes. Importantly, steatosis on imaging, the greater degree, and a higher NAFLD fibrosis score and advanced fibrosis on biopsy were associated with the development of incident diabetes. Hypertension is also associated with NAFLD, and so patients with NAFLD compared to those without NAFLD have a higher degree of hypertension, which is found more commonly in those with NAFLD who are at higher age or diabetes. So we know that individual components of cardiometabolic disease can occur because of the presence of MAFLD and MASH. We're going to focus today on cardiovascular disease because I think that's, as you know, one of the leading causes of death among our patients with MAFLD and MASH. And so to start with a case study, this is a patient that I commonly see, a 55-year-old with obesity, hypertension, and biopsy-proven MASH with stage 3 out of 4 fibrosis, tobacco use, which I think we don't ask enough about, and a family history of cardiovascular disease. He doesn't have any symptoms, however, of cardiac disease, but his PCP asks you, does MAFLD or MASH impact his cardiovascular risks, and what risk factors are important? How should this cardiovascular risk be managed? And should he be on an aspirin? And we'll touch upon should he be on a statin as well. So as I mentioned, we know that people with MAFLD or MASH have decreased 10-year survival compared to those in the general population. And it's important to note that in many studies, including this one, cardiovascular disease accounts for 25% of deaths in those with NAFLD, higher than the deaths attributed to liver disease. There are a number of potential mechanisms that link MAFLD, MASH, and NAFLD to cardiovascular disease, including genetic variants, dyslipidemia and insulin resistance, a procoagulant state, and pro-inflammatory molecules that could all lead to endothelial dysfunction, acute thrombosis, and unstable plaques that can lead to cardiovascular disease. Now, the question always is NAFLD an independent risk factor for cardiovascular disease, or does the concurrent metabolic disease lead to cardiovascular disease? And this was a meta-analysis that we conducted with Giovanni's Targer's group, looking at 36 longitudinal studies on almost 6 million individuals, and looked at 100,000 fatal and non-fatal cardiovascular disease events over 6.5 years. The presence of NAFLD at baseline was associated with increased fatal and non-fatal cardiovascular disease events with a hazard ratio of 1.4 after adjustment for relevant covariance. And interestingly, that risk increased as the fibrosis stage increased. However, there were a number of limitations to many of these studies that were included in the meta-analysis. Baseline cardiovascular disease and coronary heart disease was not universally assessed, so we didn't know how much coronary heart disease pre-existed. There was incomplete adjudication for many of the cardiovascular risk factors that we think of, and there was a lack of adjudicated cardiovascular outcomes. So this is where our group, looking at the PROMISE trial, tried to set about and determine whether NAFLD or MASLD is an independent risk factor for cardiovascular disease. So the PROMISE trial was a randomized controlled trial of over 10,000 individuals with stable chest pain. These patients were randomized to undergo coronary artery CT scans or functional testing. For those who underwent CT scans, over 3,700 had liver and spleen imaging that could determine the presence of steatosis. And about 25.5% had steatosis, as we would expect in the general population, compared to 3/4 who had normal liver. This allowed us to compare rates of incident, what are called MACE, major adverse cardiovascular events, by steatosis status, and also control for some of the limitations that I mentioned before: cardiovascular risk factors, baseline atherosclerotic burden, as you could see on CTA, and these had adjudicated cardiovascular outcomes by a panel of cardiologists. MACE, as I mentioned again, major adverse cardiovascular events, was defined as death, myocardial infarction, or unstable angina requiring hospitalization. What we found, and not surprisingly, is that cardiometabolic risk is common in those with steatosis. Obesity was found in 62%, metabolic syndrome by the ATP3 criteria in 53%, diabetes in nearly a third, and a higher total cardiovascular risk factor burden by what's called the ASCVD risk score, or the atherosclerotic cardiovascular disease risk score. This is something that our primary care colleagues are very comfortable using, and something that we should be thinking about as well. This composite score is based on things such as age, gender, race, cholesterol and lipid panels, systolic blood pressure and hypertension treatment, tobacco use, and diabetes. So it's a very good score that gives us a measure of cardiovascular disease risk. More importantly, though, patients were followed for a median of 25.5 months with an overall MACE rate of 3.1%. And baseline steatosis in these patients with no history of MACE was significantly higher in those with steatosis at 4.4% versus 2.6%. And as you can see here, with a hazard ratio of 1.72%. And this difference persisted after adjustment for things including significant steatosis on CT scan, that ASCVD risk score, which includes most, or if not all, of the cardiometabolic risks that we would worry about, as well as the metabolic syndrome. And further, it remains significant after adjustment for all CT measures of cardiovascular plaque and cardiovascular stenosis. Really getting to that answer that steatosis in the form, as we found here, of MASLD and MASH is associated with increased major cardiovascular events. And this is further illustrated here when we divided patients up by those without baseline CAD, with those with non-obstructive CAD, or those with significant steatosis at baseline. As you increase the amount of steatosis they have, you can see that each person with steatosis has a higher risk of cardiovascular disease. So overall, baseline hepatic steatosis was associated with a 70% increased risk of major adverse cardiovascular events. And this risk was independent of traditional cardiovascular risk factors, the presence or extent of CAD, including obstructive CAD at baseline on CT scan and measures of plaque burden. Really, I think getting to answer the question, is steatosis an independent risk factor for major cardiovascular events? But what about the risk factors that we should be thinking about in our patients with MASLD and MASH? So we conducted a second nested case control study from the PROMISE study, and you can see here that we limit it to those just with steatosis on imaging, again looking at MACE, but trying to determine what drove a MACE in patients with steatosis. Now, one of our outcomes was risk factors for significant stenosis at baseline on NAFLD, and we've confirmed that traditional cardiovascular risk factors were significant. So we saw more stenosis of the coronary arteries in those who were older, those who are of male gender, those with diabetes, hyperlipidemia, and those who smoked, as well as those with a higher ASCVD risk score. Other risk factors that we found included higher lipid levels, including LDL, total cholesterol, and triglyceride levels, as well as ApoB levels, a higher NT-proBNP, and a higher sensitivity troponin were predictive of more significant cardiovascular stenosis. Now, what about MACE, those major adverse cardiovascular events? Well, interestingly, two factors really were significant here. That ASCVD risk score, which is a composite score of cardiovascular risk factors, but also sedentary lifestyle was the most significant predictor of major adverse cardiovascular events in NAFLD. Now, this was something that we hadn't necessarily expected after controlling for all other risk factors, but sedentary lifestyle, which we certainly see in our patients, a modifiable risk factor, is one of the greatest risks for MACE in those with MASLD and MASH. So overall, the CAD severity and burden is associated with traditional risk factors like we think about in patients without MASLD, including several modifiable risk factors. Lipids, proBNP, and high sensitivity troponins are biomarkers for increased cardiovascular disease in MASLD. And the ASCVD risk score and sedentary lifestyle can predict MACE in these patients. So we should be using the ASCVD risk score to predict MACE and think about how to modify risk factors, and I'll talk about that in a few minutes. And importantly, focusing on physical activity to combat this sedentary lifestyle is key, as this is one of the greatest risk factors for MACE in NAFLD and MASLD. So the next question is, if we have this patient who we know has a family history, tobacco use, increased fibrosis, how should his CVD risk be managed? Well, when we're thinking about these patients, there's several buckets that we should be focused on. The first, of course, is lifestyle modification, And I would argue that physical activity, 150 to 200 minutes of aerobic exercise per week, although data exists that suggests that resistance training may be taken up better by patients with limited cardiorespiratory status and may have just the same benefit, and that can be used. Those things can combat sedentary lifestyle. Diet should be the Mediterranean diet with a limitation in saturated fat, red and processed meats, refined carbohydrates, and limiting sugar sweetened beverages. And then we need to think about these important cardiovascular risk factors. And dyslipidemia, as we mentioned before, is key. For these patients, statin therapy should be considered. And we use the ASCVD risk score calculator, adding in all their other risk factors as well as their lipid panel to help guide whether a statin should be used. The ASCVD risk factor calculator tells us what the 10-year risk of cardiovascular disease is in these patients, and more than 7.5% indicates a statin should be used. Now, we generally recommend lipophilic statins, the most common being atorvastatin or simvastatin, because those may have other benefits, including a reduced HCC risk. Hypertension is also something that needs to be treated, and we recommend ACE inhibitors or angiotensin blockers, as some studies have suggested they may have antifibrotic effects. And tobacco use is something that we don't think about much in these patients, but really quitting should be advised at each visit. Even mentioning tobacco use and quitting has been shown in a small percentage of patients to help quitting. And behavioral interventions and pharmacotherapy should be recommended to the PCP, the primary care physician. For type 2 diabetes, we've heard a lot about today, thinking about GLP-1, SGLT2 inhibitors, or even pioglitazone for management, which will help for the first two, not only with diabetes, but also potentially with MASLD and MASH and with weight. And obesity should be treated with a goal total body weight loss of 7 to 10% using a hypercaloric diet, the Mediterranean diet, considering pharmacotherapy like GLP-1 receptor agonists, and in appropriate patients, bariatric surgery. So for this patient, should they be on an aspirin? And this is a question that I get a lot, especially because, as many of you are aware, the aspirin guidelines have recently changed. So work that we've published has shown that compared with non-regular use, daily aspirin use is associated with the lower odds of both NASH and fibrosis, and daily aspirin use had a lower risk of incident adverse fibrosis compared to the advanced fibrosis compared with those with non-use of aspirin. And the effect was duration dependent, although the greatest benefit was for those who had used 4 or more years of aspirin, suggesting that aspirin use may decrease the risk of MASH, and among those with MASH may decrease the risk of fibrosis and advanced fibrosis. However, the recent U.S. Preventative Service Task Force draft has recommended that low-dose aspirin use be limited to a smaller group than we used to use aspirin for those with primary prevention, so those who have not had major adverse cardiovascular events yet. The use of aspirin for those age 40 to 59 with a greater than 10% CVD risk, again, that's assessed by that ASCVD risk score, should be an individual decision. The net benefit is considered small, but real, especially in those without an increased bleeding risk. And it's thought that that group may benefit. But primary prevention use of aspirin for those aged 60 or greater should not be used. And that's a big change from the past. So what does that mean for our patients, where we may see an increased benefit in the development of MASH and, more importantly, the development of fibrosis and advanced fibrosis? Well, it's very clear that in secondary prevention, so those patients who've already had a cardiovascular or MACE event, aspirin should continue to be used. However, for those for primary prevention and age 40 to 59, aspirin should be an individualized decision with a primary care provider and only if low risk bleeding. And this is where I really send things back to either the primary care physician, the cardiologist, and the patient to have a discussion. While there is benefit, we believe, in MAFLD and MASH, it really should be a discussion between all parties, and aspirin should not be used in those age greater than 60. So to take home our points, hepatic steatosis is associated with a 70% increased risk of major adverse cardiovascular events independent of traditional CVD risk factors compared to those without steatosis. Among those with NAFLD or MAFLD, baseline CAD burden and severity is associated with traditional risk factors, and the ASCVD risk score and sedentary lifestyle predict future major adverse cardiovascular disease events in NAFLD. But further studies really are needed to understand the mechanism that may associate NAFLD and specifically fibrosis with cardiovascular disease. Treatment calculators, especially the ASCVD risk score, which is recommended by the AHA and ACC, can help determine CVD risk modifying therapy. And hepatologists and gastroenterologists can play an important role in reminding providers that statins are safe to use in these patients. They don't have an increased risk of hepatotoxicity compared to the general population, and they can benefit significantly by decreasing the risk of major adverse cardiovascular disease events. We can also recommend that lifestyle intervention with weight loss, smoking cessation, Mediterranean diet, and specifically physical activity to counter sedentary lifestyle should be recommended to all. Thank you.
Thank you so much, Dr. Corey. We have one question. Is there any link between LPA, HSCRP, and MASLD in terms of risk stratification?
No, there is for HSCRP. That's a great question. There is increased risk of cardiovascular disease there. I am not aware of data for Lp(a), although I would not be surprised, honestly, if there was an increased risk associated there in cardiovascular disease.
The other question is MASLD considered an independent risk factor for ASCVD? And if so, do you think that it could sometime be included in the risk calculator?
It's a great question. It's something that we have looked into. It is, we believe, an independent risk factor, independent of other cardiometabolic risk. But the change that it would make in the risk score are really negligible because there are already so many factors associated that when we added MASLD in, there wasn't a significant change or reclassification.
Perfect. Okay, great. So, Kathleen, one question that popped up was whether, given, atorva and rosuvastatin are kind of just more potent and powerful, and is really the use of simvastatin kind of now really out of favor?
It really is. I find that even now some patients on their formulary have a lower copay with simvastatin, and that's really the only time that I use it. Just working with patients and their insurance company, but that's a great point that really we're moving to atorva and rosuvastatin almost universally.
Okay, great. And I think just to put in a pin on the statin point, even with elevated, and I had a case for it, but I think it deserves just discussing now. Even with elevated liver enzymes at baseline. So the case that I had, patient has ALT, 80, AST 60. There should be no fear in beginning a statin. You might see an initial little bit of a blip when you start the statin in their liver enzymes, but that generally comes back down to baseline by 6 months. And in fact, you might see improvement in their liver enzymes. Statins are even being studied in really advanced liver disease, cirrhosis, because it may have effects on portal hypertension through effects on sinusoidal endothelial cells. Kathleen mentioned perhaps a low HCC risk. I think it remains to be seen a little bit on that. But point is if we're willing to give it to cirrhotics, right, and people with less severe liver disease, we definitely love statins. They're a tremendous benefit. Yeah.
Yeah. And I think such an important thing to remember as our primary care colleagues, if they're checking LFTs, which aren't necessarily recommended anymore, but in their patients without abnormal LFTs, without NAFLD, they may see that blip that comes back down. So there's not a significant difference in this version of liver enzymes that you see with statins, with those with and without MASLD. So we absolutely, if patients have an indication, we really don't recommend withholding them.
Okay, great. So a question a little bit on steatosis and grading. Mara, you might be able to be good at handling this question. There's, when you get the EchoSens or VCTE kind of brochure, they have steatosis grades of 248, 280, whereas we saw, and I don't know, I don't see Mazen yet joining or Alina, but different thresholds to define steatosis by FibroScan. And just curious kind of what you do, because in my mind, MRI PDFF, and Kathleen, you may have an opinion on this too, picks up 5% steatosis. VCTE can only get down to 11%. So why are we pushing that cap higher? Shouldn't we be trying to pick up people with any steatosis? And just some thoughts.
Yeah, so as far as picking up anybody with steatosis in general, I don't think that's necessary, because really what determines outcome is going to be the fibrosis. So there's no good data that, higher levels of steatosis are associated with worse outcomes. So I don't know if it's that important really to quantify it perfectly well in the clinical setting. With respect to CAP, we use 288. I think erring on the side of more specificity. And, like I said, you're much more likely to have a fine steatosis when you go to the next test. With respect to MR, of course, MR is much more sensitive. I don't think that the percentages really are translatable across from MRI to CAP or for ultrasound for that matter. If you look at what a basic, entry point for steatosis in a clinical trial is, it's like 10%, right, by MRI PDFF. And that would be, if we applied that also to ultrasound or CAP, you wouldn't even be picking that person up. Right. So I don't think the scales are the same, I guess is what I'm trying to say.
Right. I guess if you're just trying to tell a patient that you have potentially MASLD, what cutoff do you use in the clinic to say, yeah, there's fat? I get the lack of correlation with clinical outcomes, but just this is your diagnosis.
Yeah, I would just, for that purpose, I would probably just use the cutoff that is provided, because that's where you're going to start to positively identify it. It's just the specificity for mostly at-risk disease is not going to be there. And that's why, usually we use a higher cutoff.
Yeah. Okay. Any other comments on that?
No. Yeah, I would say we've had more and more patients who we've seen when we use the very low cutoff and then go on to MRI, they don't have significant fat. So I do think that using that that higher threshold makes sense.
Okay, great. A question had come up from the chat about in the nomenclature, talking a little bit more about the MASLD. I think that's a really exciting area, which I think deserves a little bit of discussion. And so Mauro and others can join in here, just kind of the thought process behind that and kind of where do we go from here? Because I think that's going to be an area of active research.
Yeah, so to me, that's actually the most interesting thing to come out of the nomenclature process. And I think, we can get stuck on where to set the threshold. And you could even argue that, and there are data that more than one drink a day is detrimental to your, long-term survival, especially if you carry some extra weight. But the main point with that is that we were not able, we didn't want to change that threshold, nor was it our place to change that threshold for the definition of MASLD. So that's that. But there is this significant group of patients who drink somewhere between 20 and 50 grams a day, or their weekly equivalent, that's really not being studied, and the risk of liver disease is synergistically impacted. But I think that from a clinical perspective, we should not get hung up on the thresholds. Okay, I think we need to see it as a spectrum of disease, whereby there are two competing concepts, right? And they both need to be addressed. And that's something that, we've had lots of discussions with the alcohol field about this. We're not trying to take over their disease. We really are just trying to elevate the importance of cardiometabolic risk factors. And so even when you see a patient with predominantly ALD, you need to address their diabetes, hypertension, cardiometabolic risk. And the reverse is true. We need to ask more alcohol history. So it's just a spectrum of disease from a clinical perspective, I think.
Yeah. Any other comments? And I think we'll learn a little bit more about it. I think that we don't, because we haven't really been quantifying it very well. Patient report is everybody lies. So using more quantitative measurements like PET testing as well is something that I think hepatologists are doing more routinely. I don't know if anybody else has a comment about MASLD and the role of and kind of quantifying alcohol. No. Okay. A couple questions, Rashmi, came up on kind of the weight loss approaches. How many of your patients stop pharmacologic therapy to then choose bariatric surgery, or do you continue if pharmacologic therapy is not getting you to where you need to be, do you then can you just move on to bariatrics? So add on or substitution?
Both. I think it's a very nuanced question. I think it really depends on the patient, but yes, for patients who fail pharmacotherapy at least 6 months and they have the criteria, so BMI over 40 or over 35, and they have comorbid conditions for sure, I am recommending bariatric surgery. And for patients, you said the first part, if they stop, I forgot the part, you said they stop drug, and then would they consider...
Do you continue the GLP-1 even, if they're not getting any effect, I guess you would stop it. But I guess if they're having some effect, but not quite to target, then is that your approach?
Yeah, if they're not getting to target and they're having maybe mild effects, but not enough to quantify significant benefit, then yes, I'm going to set them up with bariatric surgery. And generally, I do stop everything at bariatric surgery. Okay. So yeah, for sure.
Okay. And I guess with the effects on motility, it could be problematic with surgery and post-op. If there's any GI motility issues, it could be a complicated post-op course on a GLP-1.
Yeah, that's why I try to sort of wait at least the first 3 to 6 months and say, okay, let's see what happens, see how you do. And then really until they reach that sort of lower threshold of their weight. But if they're worried about regain, then we can consider restarting it.
Okay. And another question related to kind of the cost difference between pharmacotherapy and bariatric surgery.
I think there need to be studies to test that. Yeah. So I think definitely the cost, these drugs are so expensive. So, and we're still running into challenges where commercial insurance plans are not covering them. So I
don't think Medicaid covers them at all. And so
Yes,
that
Medicaid,
brings up
Medicare.
kind of the disparity issue where if the population who might benefit tremendously can't even get it.
Yeah, this is where patients with Medicare, Medicaid, we have to prove they have some form of type 2 diabetes. And even now they're getting more and more strict. We before used to say, oh, this person might have pre-diabetes. Let's see if we can get them a GLP-1 now. They're like, no, that A1C threshold, it has to be true A1C over 6.5, true type 2 diabetes to get these drugs covered. So it's a very, very challenging environment right now, unfortunately.
And I've heard, Maru, you got a comment?
Yeah, I just wanted to make a comment about GLP-1s and specifically for MASLD. This is actually a perfect population to do that because you also see reduction in alcohol cravings with these drugs. So that's kind of an additional reason to sort of consider them. And there are targets that are going to be developed that are perfect for this as well. HSD17B13. There are lots of ways where we have synergy.
Yeah, and I believe Novo is doing a study for alcohol use disorder and GLP-1s. So I think more to come on that. Certainly very, very interesting area of research.
Well, we can
Go ahead, Scott, you had a comment?
I was just going to say, if we're lucky, it'll be a little bit like the Hep C drug story, which started with drugs at $75,000 for a cure, and before you knew it, with other competitors, the price came down. And certainly there are many competitors in drugs coming out for weight loss. So that may be to our patients' benefit financially.
Sure. Yeah.
Great. A question came up on, there's a couple questions on HCC choice of therapy, Augusto. So does MASLD affect the choice of therapy for HCC?
Yeah, so the short answer is no. There's data, and Scott showed a slide where there's experimental data that suggests that patients with MASLD had lower rates of response to checkpoint inhibitors. And this is based on meta-analysis of the trials that were using these medications. But there is some heterogeneity in the studies, and the most recent trial didn't show any difference according to etiology of the liver disease, differences in response. So the consensus currently is that the treatment of HCC, at least the systemic therapy, should not depend on the etiology of the liver disease.
Great. And then there was another question about surveillance besides ultrasound. The standard ultrasound and alpha fetoprotein every 6 months. Do you ever really try to push for the MRI?
Yeah, so the AASLD guidelines on HCC were published a couple of months ago, and they mentioned specifically that if the quality of the ultrasound is not good enough for an adequate assessment of the liver, the patient should go for cross-sectional, ideally MRI. So in my patients, we generally alternate MRI with ultrasound to avoid the issue with insurance. Generally, insurance, they are more prone to pay one MRI per year. So that's how we solve it. But I have to say that I had some patients with MASLD cirrhosis where the ultrasound is very poor, and the insurance had some pushback, but you do the appeal and you explain the situation, and they were fine. So what I would not recommend is CT scan, because the amount of radiation is significant for a procedure they do every 6 months. But the sensitivity of MRI is increased compared to the ultrasound. And there are new modalities of MRI that are being tested, what's called abbreviated MRI or AMRI, where the length of the procedure is much shorter. You can do it in 15 minutes, it's cheaper. And I think it's a very good solution for potentially solving the poor quality of ultrasound.
Along the HCC path here, any proven correlation between alcohol consumption, even minimal quantity daily, and risk for HCC development?
No, so for alcohol is very interesting because the risk of HCC in alcohol use disorder is closely associated with the development of cirrhosis. So it's relatively rare to develop HCC in patients with alcohol use without cirrhosis established. But it's also interesting that so the etiology that provides the highest risk in HCC is a combination of hemochromatosis plus alcohol use, by far. So alcohol in certain circumstances magnify the risk of HCC, but on its own, there is no evidence that induces HCC before the stage of cirrhosis.
Well, that brings up a good point about the ferritin level that I guess Manal brought up, that a lot of times you see elevated ferritin in patients with MASH. And so certainly if it's not greater than 1,000, you don't do genetic testing, but is that potentially something that could be within the MASH population, a risk factor for HCC, or you think probably not?
I don't know. As far as I know, the studies that try to identify predictors of HCC development in MASLD, ferritin was not among the top reported. But to be honest, I don't recall it has been thoroughly evaluated.
Okay. Mauro, is your hand still up from before? Or did you have another comment? This is from before. Okay, no problem. The question on GLP-1s, if they decrease alcohol consumption, are we addressing the alcohol craving in alcohol use disorder? So in alcohol use disorder, the drugs that are being used like baclofen, and others can pipe in on drugs that they're using, they are targeted at things that try to decrease the cravings. So I think that is that is the goal when you're trying to treat alcohol use disorder. I don't know if anybody else wants to make a comment. And then the GLP-1s, it just happens to be an added benefit that has been discovered actually almost accidentally.
Yeah, no, I'll make a quick comment about that. So I think in general, the use of medications to reduce cravings in alcohol use disorder is very, very low, at least on a hepatology scale. There are many hepatologists who don't prescribe them. I think that's not right. To be honest, I really think we need to be better as a society to do that. I either use baclofen or a camprosate most of the time. But no, I think we need to emphasize how important that is to help support our patients to be abstinent. And yeah, GLP-1s reduce craving actually as well.
Yeah, and baclofen's pretty safe. That's the one I always start with because it's actually even safe in those with advanced liver disease. So I've been it's about getting used to doing it. And so that's really the one that I've been using a lot. I think a camprosate, the pill is like a horse pill. It's like really large. People have a little bit of a harder time with it, but I think, and even in primary care, there's no reason why you can't try baclofen low dose and then just titrate up to get their desired effect. Okay. Scott, there was some questions about, and Jamie had talked about this a little bit. You mentioned the role of potential microbiome in MASH fibrosis and progression. And she talked a lot about kind of the catchment area that we are in Sinai and that there's hot spots really, right? And so it could be genetics. We have a high Hispanic population, but could it be microbiome because of dietary, environmental factors? And how do we tease out those two things, if at all?
It's not easy because diet affects microbiome, microbiome affects appetite, appetite affects fat. So where it starts is hard to know. One other point that I've learned from Andrea is don't overlook the impact of environmental pollutants. And so the high prevalence of poor air, particularly in cities and particularly even in some neighborhoods, the high prevalence of asthma, particularly in parts of New York City. I think these are all elements that make it so difficult to disentangle the multiple inputs that ultimately generate this disease. I'd also point out, as you know, that specifically the Hispanic Americans that have the risk polymorphism tend to have originated from South and Central America and Mexico. New York City, of course, has a large population of Puerto Ricans and Dominicans and Caribbeans. I don't believe that their prevalence of PNPLA3 is anywhere near as high, so it's important to make that distinction. Then one final point related to your prior discussion, I think there's a growing recognition that the wiring around craving or addictive disorders is very similar across different diseases. It can be opioid use, smoking, appetite and eating, or alcohol. And so it wouldn't surprise me, although it needs to be tested rigorously, that the reduction in food cravings associated with GLP-1 also carry over to cravings for other substances. And I think, one of the things New York Times has written about, probably one of the best articles about this, saying that first of all, the mechanism of action of GLP-1 agonists is entirely obscure. Nobody knows why they are, well, we know what they're agonizing, but we don't know why patients lose weight. But they not only lose weight, they stop being hungry and stop thinking about food all the time. And so I'm cautiously optimistic that we're going to learn a lot more about the wiring that underlies addictive behaviors of any type, and that quite a bit of that will be relevant in that MASLD.
Andrea, you want to make a comment about kind of, lead in these communities and how that could be a cofactor?
You're muted, Andrea.
You're on mute.
Yeah, I definitely think that we have underappreciated the impact of toxins as a cofactor driving liver diseases. And I also feel going forward that we need to make more of an effort to take a whole body approach to analyzing these pathways. So, presuming, for example, that fat may be very sensitive to hypoxia, and that transient hypoxia might be a cofactor for liver fibrosis, making sure that when we do these studies and we're trying to identify risk factors, we not only consider the environment, but we also consider other parts of the body that are getting affected adversely by some exposure, with a hit to the liver as a downstream consequence. Certainly, studies have been done in people with sleep apnea, for example, showing that there's an association between the lowest level of oxygen saturation and liver fibrosis. So I do think, it's complicated already. We have a lot of things to look at, but I don't think that we've done enough at looking at interactions between different organ systems when we're trying to understand what's going on in the liver. So I also just kind of would underscore the points that have been made about these GLP-1 receptor agonists as potential tools for assisting people with all kinds of addictive disorders that are causing problems for them. It really hasn't been looked at very much, but there's certainly some dramatic anecdotes that you read about. So, I'm very hopeful that they may be quite broad spectrum tools that we can use to help patients that have various types of addictive problems.
Great, thank you. So kind of on practical kind of questions, when providers refer their patients for elastography as per the algorithm, just curious from the group, the question is what interval should that be repeated? As we know, the guideline in the AGA pathway says if it's less than 8 to every 2 to 3 years. I think some people have said with diabetes, it should be done annually. So just curious, in the real world, what do you guys do or recommend to patients for a repeat FibroScan? And are there certain values that dictate that repeat? Kathleen, you want to take a stab first?
Yeah, I'm generally doing the every 2 to 3 years. I do, which is totally of my own making, do a FibroScan initially, then I repeated after 1 year to make sure that we have very consistent data. And then if we do, then every 2 to 3 years, if they're less than 8. And I talk with the patient more if they're higher. We may be going on to MR elastography, and that will change our or liver biopsy if need be. That would change our future screening, but every 2 to 3 years. I'd be interested though in what other folks are doing.
Yeah, I'll move to Maru in a second and Augusto. And Scott, I think you just hit on something. There was a question earlier in the day about kind of when you have inconsistent results, like the FIB4 is here, the elastography is here. MRE is kind of what I consider the tiebreaker. So if you have access to it, and of course not everybody does, but if you do have access to MR elastography, that's kind of, I think right now considered the tiebreaker, and it's less susceptible to issues with obesity. And, so you really can get, and it's obviously a larger part of the liver. So that is, I think kind of what we do because we have access to MRE. I think the other question was ELF versus VCTE, whatever you have access to. But I think Mazen had said if you have VCTE, we just have a lot more data for it. ELF has been done mostly in the context of clinical trials. So when you have a low prevalence of disease, kind of in the screening population, it remains to be seen how well it performs. I think we're going to get a lot of data on that now that it's FDA approved. So Maru, comment on interval for elastography.
Yeah, so thank you. And I completely agree with Kathleen. I think that's totally appropriate. I will say that in a sort of quaternary care practice with FibroScan right at your side, I do many more of them than we advocated for in the guidelines. And part of that has to do, I think, with, increasing data that change over time is meaningful. So if you're changing, if your FibroScan, if your liver stiffness is increasing over time, that means something and actually is impactful from even an outcomes perspective. So I actually do check it because it's easy and I have it more often. If you had to refer somebody, I would not do it more than every 2 to 3 years. I completely agree with that. And with the ELF thing, we struggle a little bit putting ELF in the guidelines because there, as Mina said, there really isn't enough data in a low prevalence population to really know what the performance characteristics are. But the way we looked at it is if you don't have access to FibroScan, it's better to do that than to not do anything at all. And it certainly is, I think, very informative. I'm really looking forward to more data coming out on that, but I use it regularly. I order it regularly.
Augusto, your practice?
No, the same. I mean, we have also very easy access to FibroScan, so I use it, very commonly. I say I would do yearly FibroScan for patients with F2, F3 to see if they change. And I find it interesting, the data on what happens all the time, because the time trends on how changes in FibroScan values could impact outcomes. I think that would be even more informative than the baseline data. So yeah, but probably I use it more than I should.
Well, patients like it too.
I think that's right. I think it's a really good, yeah.
It's just not really. It's not invasive.
In my case, they love the when the CAP score decreases. It's like their objective. They don't care so much about the fibrosis score, but when the CAP score goes down, they're super excited and motivated. I find it a huge motivator for them.
Yeah, I agree. And I'll add though to that when the CAP score doesn't change, then I'm like, well, it's really not good at measuring dynamic change or whatever. But it is an important tool, I think, for motivation for patients too. So to your point, yeah.
Yeah. And there was a couple comments related to the CAP. So I agree. I mean, in our longitudinal registry of NASH patients, which we have about 500 so far, I mean, we're doing annual, right? We're doing annual VCTE. We're doing annual FIB4, again, to look for the patient's slope. I think I made the point earlier. Some people stay F2 for their entire life, right? But some people go much faster and some people regress, right? So you really need to understand there's one thing to look at things at a population level, but at an individual patient level, they want to know if the activities that they're doing is having an impact, positive, negative, or otherwise. So I think huge motivator. We're lucky because we have it. It's basically part of our physical exam at this point. So we have access to it. There was a question about how would you counsel a patient with severe steatosis and no fibrosis? What is risk of progression to fibrosis? How about Scott? You take that one.
We really don't know. I mean, that's why I emphasize that why some patients have profound fat accumulation and little or no inflammatory activity is uncertain, except that the mechanisms for fat accumulation are different than the ones for inflammation and fibrosis. So I think the prevailing theory is that that all fat is not created equal, that there is fat that is so-called lipotoxic that generates free radicals and other soluble mediators that injure and inflame the surrounding parenchyma. But I think that the presence of fat alone still is a tip-off that the patient has metabolic syndrome. Sometimes that may be the only indication, particularly if they're not diabetic. So at the very least, if the lipids haven't been checked yet, that will obviously mandate not just checking lipids, but a much more comprehensive assessment of the patient's metabolic state.
Yeah, go Andrea.
I feel like I'd really like to see more longitudinal data to find out if those people who have severe steatosis but don't have fibrosis are really going to stay in that state, or if there's some capacities that the liver has to deal with that stress of having that big lipid droplet, but that eventually they can't deal with it anymore, and that it gives rise to fibrosis. And so I think one of the great things about having an easy tool like FibroScan is it does make it easier to follow people. But in some cases, we may need to follow people, not for 5 or 6 years, but 20 and 30 years to see if there really are people who just have S3 steatosis and they're just fine with that. I don't know. I don't feel like I've seen enough data to say if that's really an okay state, or if they are going to progress to a different state. Scott, do you have any thoughts about that?
The more risk factors that add up, the more likely, but that's the best I can say. Genetics, environment, microbiome, activity, but how each of those contribute and whether they're really important in converting a plain steatotic liver to one that has inflammation, I think this is one of the great mysteries.
Yeah. There's a question that's come up that, we've talked about advances in these non-invasive assessments, VCTE, L, FIB4 calculation, MRE, all of which are potentially available to PCPs. So the question is what should be the trigger to refer to hepatology? Anyone? Feel free to pipe in. I mean, I think if they're F2 or higher, you want them potentially in a clinical trial, which could be only available with hepatologists potentially. I mean, I guess there are obviously others who could be involved with clinical trials, but I think that that's certainly one aspect of it. And if drugs are available, which I think there will be treatments that are available next year. That is my prediction. And so will the PCP be comfortable in initiating that? Will the insurance company mandate that they are seen by a hepatologist to confirm, how are they going to be determined to be at risk NASH and then be eligible for therapy? So I think those are key considerations. Anybody have other thoughts? So the question is with all the NITs available for Tatiana Manalo just joined, at what point, do they even need to see a hepatologist? If PCPs have access to VCTE, MRE, health? Why do they need to see a hepatologist?
Manal, we should let you answer this.
Uh,
I think our algorithm went through
Yeah,
like 25 iterations.
yeah, I'm a strong believer that patients who have advanced hepatic fibrosis or cirrhosis should be under the care of a hepatologist for longitudinal follow-up and appropriate timing and referral pathways for transplantation or so forth. Yeah, as a hepatologist, I'm completely comfortable with caring for the metabolic syndrome and its hepatic manifestations in primary care when there's low risk. But I think there is an appropriate home, if you will, for patients with more advanced liver disease. That's my personal take. And so if the NITs are reflecting advanced hepatic fibrosis or cirrhosis, I think a referral pathway is appropriate. Now, I don't know if that's, in my opinion, consistent with others, but I'd be interested to hear their thoughts.
I mean, I think certainly where we have most comfort, I think, is in saying that if your FIB4 is less than 1.3, you don't need to refer that patient. That for sure is going to be true unless there's something else telling you that they have a more advanced disease. So I think people who have a very high FIB4, greater than 2.67, they should probably be seen by a hepatologist, or people who have intermediate high on secondary testing, those should probably be at least evaluated and then maybe sent back to PCP. Because remember, like probably 97% of these patients live in PCP and endocrine land, not in hepatology space.
I also am a strong believer that probably as drugs become approved for the indication of NASH, that they're going to be used in the home of a hepatologist so that the at-risk NASH patient, getting at what Maru is saying, likely will only have access to some of these emerging therapies by a hepatologist until the comfort and adaptation of prescribing and follow-up on therapy becomes more broadly adapted by primary care endocrinologists.
Tatiana, any thoughts?
Yeah, I mean, I agree with what everyone was saying, and obviously, once we have medications available, then it will likely stay in the hepatology domain for a while. I mean, even with hepatitis C, there has been for years a big push to have primary care providers really take on hepatitis C treatment, and the uptake for that hasn't been excellent because I think primary care providers have many other conditions that they're dealing with, and I don't know how many of them are that eager to take on yet another condition of NASH. So I agree for sure. Advanced fibrosis and in general, I mean, of course, it will depend on the primary care provider, but many may not want to take on an additional liver disease to manage, in addition to everything else they're doing.
Well, Rashmi probably sees a good number of patients. So she's endocrinology, sees a good number of MASH patients. At what point do you refer to hepatology?
Yeah, I mean, I think that's sort of the challenge. I think patients come to me already saying, oh, I have this elevation in my liver enzymes. Oh, I know all about this. And so I think, yes, I obviously emphasize the weight loss, and that's what our goal is. But you're right. I do recommend it. I will say there's some pushback sometimes because patients, they're like, okay, you're sending me to one more doctor. But I agree. I think there needs to be more aggressive push to have these patients be evaluated and formally followed.
I think also ruling out the other causes. Sometimes, I mean, I see that primary, some tests will be done. But, I don't know that necessarily primary care is looking for Wilson's disease or celiac disease in every patient who presents with steatosis, but we do. So when they come to us, we're making sure that there is no other modifiable disease that could be mimicking actually steatohepatitis. And so just because they're obese and have diabetes doesn't mean they can't have Wilson's disease. And that is a diagnosis you don't want to miss. So I think that at least a one-time evaluation, right? A thorough evaluation, confirming the diagnosis with clear inclusion criteria, and then perhaps having some kind of dialogue or, kind of coordination with primary care, endocrine, cardiology, et cetera. Other questions that have popped up. The role, so we talked a little bit about lean MASH and the kind of idea, like a lot of the Asian population, they look thin outside, but they're fat inside. I think one of the people in the audience called it, I think, TOFI. What is it? I think they called it, yeah, thin outside, fat inside. I never heard that before. But ways to diagnose that, right? So DEXA scan now is a potential to look at visceral adipose tissue, CT scan at the L4 region. Certainly, I don't know that you would do an MRI for this, but that would certainly do it too. I don't know if anybody else is doing anything routinely to specifically diagnose visceral adiposity. And then, of course, we talked about waist circumference and waist to hip ratio as good ways to do it. I wish I did it more. I think waist circumference is underutilized because it's just a pain, and you need to get your MAs to do it. But I think we need to start doing it more. I don't know if anybody else ever uses any kind of assessments to look specifically at visceral adiposity in those with lean MASH or lean.
I would say clinically, I don't do that usually. I mean, I think the diagnostic criteria, the new diagnostic criteria, will pick up 87% of those people. So better than we were doing before. I think in those particular patients, you need to go that extra mile to make sure they don't have something else too. Alcohol is a super important thing. People miss it all the time. Lysosomal acid lipase is not common, right? So I wouldn't even, that's not really where I'm going, but there are, people who have very significant dietary habits that are going to be, and, promote that steatosis in the liver things, so just think of other diseases also.
I agree fully. There's usually a dietary precipitator. I found that very high sweetened beverage consumption is one of them. Soda drinkers. Obstructive sleep apnea is quite prevalent in the Asian population just because of the anatomy of the jaw and the oral pharynx being somewhat smaller. In the olden days, when I had a patient with fatty liver disease and all other serologies were negative, and they appeared thin on the outside, but quote, this fat on the outside before all our DEXA and understanding of visceral adiposity. I would do a 2-hour glucose tolerance test, and it was amazing how much you can uncover prediabetes or diabetes with a stress. And so, in fact, while they appear thin, they probably may be in the spectrum of developing more clinically significant insulin resistance, and they may not be diabetic, but you can uncover impaired glycemic control.
Yep. Yeah. Any other comments on that? Yeah, Andrea.
Yeah, so in my talk, I showed some data about the relationship between all-cause mortality and BMI. And I showed data for African Americans versus Caucasians. And certainly for Caucasians, there's a quite steep slope that relates increased BMI to increased mortality. And in African Americans, it's really very flat. There's a massive study that was done in Asia looking at different Asian populations, looking at the relationship between BMI and all-cause mortality. And for Koreans, Japanese, and Chinese, it's kind of a curve that has a high peak at low BMI and has then an increase, like with Caucasians increasing with BMI. But in Indians and Bangladeshis, there was not a relationship between all-cause mortality and increased BMI. The group that had a significantly increased BMI was the people who had low BMI. They had the increased mortality. So, this kind of data has just raised for me all sorts of questions about the relation. What is a healthy body weight? It seems as though if you take I always think dying is the most important metric. So if you take dying as your metric, it seems like maybe our understanding of the relationship between body weight and mortality is true for some populations, but it may really not hold for other populations. And I would just mention that in the Asian study, it was such a large study that they were able to, they could get rid of everybody who had a history of smoking. So they could tell that the relationship between low BMI and high mortality was not because low BMI was associated with smoking. And they could also eliminate anybody who had mortality within the first 3 years of the study because it was a very long longitudinal study. And they also eliminated anybody who at baseline had a diagnosis of cancer. So they were kind of just left with this enigmatic finding that for Indians and Bangladeshis, it was really low BMI that was associated with mortality. And interestingly, the excess mortality was almost entirely due to respiratory disease. So I suppose you could argue it was because of undiagnosed tuberculosis. But anyway, I just kind of throw out
or toxins, Andrea. You know, in India, in toxins, the pollution is crazy. And certainly those of lower socioeconomic status may have more exposure to toxins. And so the low BMI, you know, is kind of feeding into that. So possibility.
I think that is a possibility, but I also think it's possible that our understanding of the global ill effects of overweight are those understandings that we have may apply much more to certain populations than other populations. And you know, I'm curious for some feedback about this. What do other people think about this?
Scott?
I can't address that as much as if you indulge me, I want to just return to the lean MASH syndrome, because that really is a perfect setup for the microbiome being the determinant. In other words, is liver fat really necessary, or is peripheral adipose necessary? If you have a NAFLD or MASLD inducing microbiome, you know, maybe that's all that's necessary, combined with the genetic factors that are unique to Asians who are more prone to lean MASH. There are a handful of studies, somewhat controversial, that suggest that there are certain patients and certain bacteria that generate alcohol in the gut.
Yes, that's so interesting, right?
You know, there is a plausible connection between the microbiome and the direct development of liver fat that doesn't require, you know, systemic metabolic syndrome or systemic obesity. If that patient has an overgrowth, it's called autobrewery syndrome. And there have been a couple of interesting studies, one from China where it was Klebsiella, and then a study from the Netherlands that actually sampled portal blood. So I think it's, you know, it's one of those wild cards that may account for some patients having a MASLD syndrome in the absence of the metabolic syndrome.
That's a really good point. And I would say, I think Anna Maydeal 20 years ago talked about that. I remember. So yeah, she's, yeah.
Manal, you had a comment? No. Okay.
No, I fully agree.
Yeah, I just want to, on the pregnancy issue, we had some cases, but we're covering a lot of ground just kind of through the audience participation, which is fantastic. Tatiana, we've talked about we've talked about this FIB4 and ELF, you know, and this whole pathway. But I think in pregnant individuals, really, you're just using VCTE. Any comment of FIB4 or ELF in pregnancy?
Well, I think the challenge is that they're not really validated in the context of pregnancy, and I think we need to do that. For example, platelet count can be lower in pregnancy due to hemodilution. Technically, ALT and AST should not be affected, but I think that in order to be able to comfortably use them and interpret them, we need to validate them in the pregnancy context, and same with others such as ELF. So, you know, we're not routinely using them, but as we're doing our FLIP, fatty liver in pregnancy protocol, we are collecting all the laboratory parameters. So we will look at them and try to correlate them with findings on FibroScan. I think even what we've seen is that our assessments on ultrasound compared to steatosis on FibroScan, the CAP scores don't correlate very well. And part of that may be related to the fact that we're doing them at slightly different times in pregnancy, maybe about a month apart. I don't think that would make a huge difference, but we're not seeing as excellent a correlation as we would like to. The other part of it is that, as we all know, ultrasound is very susceptible to inter-rater and even intra-rater reliability issues. So we're working on trying to kind of understand that, but also FibroScan is relatively new in pregnancy. It was just approved for use. So I'm not sure if the CAP parameter is affected by the pregnant state. All I could say is that we did see obesity and Hispanic ethnicity as significant predictors, which suggests that it does make sense what we're seeing, but clearly, I think we still need to know more. I think it would be beneficial to actually have some MRI data in the context of pregnancy, PDFF and MRE, because I think that if we can correlate what we're seeing on ultrasound and FibroScan with more sophisticated tools such as MRI PDFF and MRE for steatosis and fibrosis or liver stiffness assessment, then I think we will be more comfortable using ultrasound and FibroScan moving forward.
I have a question for you, Tatiana. Is it a problem having fasting prior to the FibroScan for pregnant women, or you don't find asking them to fast for 4 hours to be a problem?
It is a huge problem. So we call them the day before they come in and remind them, and we offer them bars, like, the bars that you eat after, to tell them that, you'll get a snack right after. But despite everything that we try to do, they come in for the FibroScan and they're eating an apple or, so, and I don't blame, it's really hard to not eat during pregnancy. So for sure, that has been a barrier and probably the top reason for why people are not getting the FibroScans in our protocol. We're also giving them reimbursement, but even that, when you're hungry, especially during pregnancy.
I've wondered generally if one of the reasons why FibroScan comes out looking slightly less good as a tool compared to MRE is because people don't take that admonishment to fast seriously enough, and that you just have more FibroScan readings that are thrown off by the failure to fast. We did a study in the World Trade Center cohort, and we found it such a problem. We would get some pretty crazy recordings, and then when there was follow-up, it was almost certainly that we just, no matter what we did, we were not able to persuade people to fast. And so,
yeah, for sure. And body habitus too. Getting accurate FibroScan reads and people with very high BMIs is really challenging. And pregnancy doesn't help either.
Okay, we have the one final question for the afternoon, which is, in your expert opinion, what's the predicted rise in MASH or MASLD in this decade and beyond? Are we going to see a downward trend of incidence? And I suspect you're implying because of the widespread use of GLP-1s. So I will start. We're going to ask everybody their opinion here. So I'll start with, anybody want to start with their thoughts?
I'll start and then I think that at least based on, the Estes paper, we can expect not just increased prevalence overall, but high enrichment in advanced disease. So that's on the order of, 168, 178%, increase. So that's probably, we're going to see more of that. How much of an impact GLP-1s will have? Of course, the paper was written before GLP-1s. at least widespread use of them. So I don't really know. And I'm not convinced that GLP-1s are going to make a humongous impact. And the reason is that if you follow people for a year on GLP-1s, it's really, you're looking at about 30% of people are still on them after a year. So I don't think it's going to be a big impact on a population level, at least.
Kathleen, you want to make a comment?
Yeah, no, I totally agree. I mean, I think GLP-1s are great in some ways, but I have a lot of patients who don't tolerate them. I have a lot of patients who can't make it to the 6-month mark. And most of my patients are very convinced that they can lose the weight. If they are losing it, then stop them and keep that weight off. And we're not seeing that. So I don't think that they're going to make as much difference. And I do think we'll be seeing an increase overall in fatty liver or MASLD.
Augusto?
Oh, I agree. Yeah, nothing to add.
Andrea?
I think it is going to, unfortunately, there's a political dimension to it. I really think we need some regulations of what people are eating, and the potential for having any positive impact on that seems kind of dimmer by the day. Certainly our mayor tried to have an intervention that would reduce consumption of sugary soft drinks, and it did not go very well. So unless there's some public health initiative, we certainly were able to intervene with smoking, and after the Surgeon General report came out about smoking, people did decrease smoking, and I do think that improving diet could have an impact on this. So I'm hopeful that there will be some public health and some public policy changes that help make this problem less. It's hard to be optimistic, but I'm trying to be optimistic that will be the case.
Okay, Manal?
Yeah, I fear that we're going to, at least with the existing cohort of patients who we know have NAFLD and NASH, see a rise in advanced hepatic fibrosis and its complications. I am hopeful that we can get on the bandwagon with changing public policy, because for our children and adolescents that are coming up, it's going to all be about primary prevention and change the trajectory of these curves. And if we can increase activity in schools and change diet and black box, sweetened beverages and so forth, that's how we're going to change the trajectory. But I think we'll continue to see a rise in those patients who have clinically significant NASH and fibrosis, at least over the course of the upcoming decade, and pending a very effective therapeutic. And I don't think it's just going to be GLP-1. It's going to be a combination approach to shift that. But we really have to target primary prevention to change public health.
Tatiana?
Yeah, I mean, I agree with what everyone is saying. Every subsequent publication about global epidemiology, the numbers seem to be getting higher and higher. And so at the moment, it doesn't look so promising. But on the other hand, I do think there is much more attention to NAFLD and MASLD now than there was before. So hopefully, more public awareness will help in terms of screening for it and linkage to care. But I think we also have to be careful with, in line with this GLP-1 discussion about disparities, also like who is accessing these medications and who will benefit compared to who actually will not be benefiting from these new exciting medications, and how that will make the population look in terms of who continues to have an increased risk and who maybe in which populations it may get better.
Scott, last but not least.
I think the disease prevalence is beginning to crest, but it's cresting at an unacceptably high level. When you have 30% of the world's population with fat in their liver, that's not a place you want to be at. And I hate to be a skunk at a garden party, but I'm skeptical that we're going to make any major inroads on a population basis for the next 5 or 10 years. because we first of all have to disentangle the cause of the disease, and then we have to validate and implement public health policies that are proven to work, and they have to be sustainable. That's my concern about all the GLP-1s, is that they're only approved for a year. And, this is a lifelong disease. Imagine if statins were only approved for a year. We'd say, well, what good does that do? Patients are still going to be at risk for heart disease for the rest of their lives. So I think there's, a lot of work to be done, which is why we should keep meeting every year.
Yes, yes. So we're going to close now. I want to thank the panelists who could come back and join us.